Inovocare E-Academy.
In a sound and gondogol dekhi hamari tai.
Yeah, we can hear you. Dr. Dash, we can hear you. So, on behalf of Inovocare Healthsoft Solution and E-Academy, with our privileged society, that is Geriatric Society of India, we are going to organize our CME, and I welcome you all in this CME, that is Treatment Adherence in Elderly Healthcare. So with that, I want to introduce our Honorable President of Geriatric Society of India, Dr. Kaushik Ranjan Das. Dr. Kaushik Ranjan Das is a consultant family physician and geriatrician in West Bengal. He is a very noted person in the field of geriatric care. I request Dr. Kaushik Ranjan Das, sir, the President of Geriatric Society of India, to inaugurate today's session. So welcome you, sir, and over to you, Dr. Das.
Before Dr. Das takes up, may I request everybody else to please put yourself on mute. When the speaker will speak, all of us will mute ourselves, please.
Can you hear me?
Yes, we can hear you.
Sir,
We can hear you, Dr.
Namaskar. Yes, I'm starting. Namaskar. A very good afternoon to you all. Respected patrons of GSI, those who are our inspirations, Dr. P.S. Shankar sir and Dr. V.K. Arora sir, General Secretary of Geriatric Society of India, National Professor, Dr. Opi Sharma sir, immediate past President of Geriatric Society of India, Dr. Prabha Adhikari Madam, respected patron of Innovocare Healthsoft Solutions, Professor Dr. Shantanu Tripathi sir, other office bearers of Geriatric Society of India and Innovocare Healthsoft Solutions, esteemed faculties, and all respected participants of the virtual CME. I welcome you all at this virtual CME on treatment adherence in elderly health care. Being organized by Geriatric Society of India in collaboration with Kolkata-based institution dedicated to healthcare, Innovocare Healthsoft Solutions. Today we are going to deliberate some aspects of very important and pertinent issue in geriatric healthcare, that is treatment adherence. Luminaries in their field will be joining as faculty. I hope the CME will be an enjoyable and will provide long-lasting outcome. I am privileged and honored to inaugurate the CME. I declare the CME program open. Thank you all. Namaskar. Now over to Shambhu.
Thank you very much, sir. Now I request Dr. P.S. Shankar sir, Professor P.S. Shankar sir, who is an eminent in this field of geriatric medicine. He was Emeritus Professor of Medicine and Senior CEO, KBN Teaching and General Hospital, Kalaburgi, Karnataka. And he is the patron of Geriatric Society of India. Sir, please give your valuable note today and give your blessings to us. Over to you.
Thank you. Thank you. Dr. Kaushik, Dr. Arora, Dr. Prabhat, Dr. OP, Dr. JK, and friends. I am happy to join the program on the treatment adherence in elderly healthcare. The success of any treatment is primarily determined by the adherence to the prescribed treatment. Any deviation from it brings down the clinical benefits Adherence is a medication regimen has been defined as the extent to which the patients take medications as prescribed by their healthcare providers. Good adherence improves the effectiveness of interventions aimed at promoting the healthy lifestyles and of the pharmacological based risk reduction interventions. It has been observed that adherence is better among patients with acute conditions than those with chronic conditions. Patients suffering from chronic disorders that include the elderly patients often discontinued the medication after some months. Poor adherence to the treatment of chronic diseases is a worldwide problem and it is commonly faced in the health system. Often, many patients find it difficult to continue long-term therapy with the medication due to the financial constraints. Poor economic status prevents them to spend money on medicine for a long period of time. Many a times, they are prescribed multiple medications and they find it difficult to procure them. Thus, there is a great need to optimize the medications. The healthcare delivery system should strive to improve the patient adherence. Behavior improving adherence is the best investment for tackling the chronic conditions effectively. Poor adherence to a medication regimen leads to absence of desired response to the therapy. The hurdles to achieve a high rate of adherence include multiple expensive medications, complex dosing schedules, food interactions, side effects, and lifestyle factors. The healthcare delivery system should strive to improve the patient adherence. Behavior improving adherence is the best investment for tackling chronic conditions effectively, especially among the elderly patients. In this background, the current program is relevant, and I congratulate the organizers for organizing this to draw the attention of the practicing physicians. Thank you.
Thank you, sir. Thank you very much for your blessing, sir. So may I request Professor V.K. Arora, who is an Emeritus Director of NDTBC, New Delhi. He is Senior Consultant of Respiratory Diseases and ex-Vice Chancellor and Head of TB and Chest Disease Department of Santosh University, NCR, Delhi. So, welcome you, sir. And today's keynote address will be given on the topic that is treatment adherence in national programs by him. Welcome you, sir.
I will just take 5 seconds. Firstly, I would like to inform everybody that Professor P.S. Shankar is the only person in Karnataka who, from the field of medicine, who was awarded the title of Nodoza. Nodoza means teacher of teachers. And secondly, about our second patron, Professor V.K. Arora, he has been requested to deliver the keynote address on treatment adherence in national program because besides being director professor and head of the department of LRS and then the vice chancellor of Santosh University, he also occupied the chair of additional director general health services and was a part of the many national programs. So we wanted to hear his experience. That is the reason we invited him and he has very kindly accepted the invitation. Over to you, Professor Arora, sir.
Good evening, everybody, and thank you very much, Professor Sharma, who is our dynamic secretary at all India level, and whose effort has seen the Geriatric Society to grow to this level. Thank you very much also to our President Kaushik Ranjan Das, who has been at this moment heading the Geriatric Society of India. And also thanks to our patron, Dr. Shankar, whom you just heard. These are the stalwarts, apart from other stalwarts who are present today. I'm quite aware about many of you. and like Professor Adhikari and others who are stalwarts in the field of geriatric medicine. Thank you very much. Thank you very much, Dr. O.P. Sharma, for introducing me. And probably that may be the reason, as I was the director of National Institute of TB and Respiratory Diseases, as well as I saw certain national programs very closely when I was Additional Director General Health Services, Government of India. Well, all this, my stay in these areas were related with one, the National TB Control Program, and I was very much involved what we call it as a DOTS strategy. And we all know that directly observed treatment short course is all program, nothing but it is the compliance of the therapy. It is observation of the therapy to the patient which we used to give to ensure that the compliance of the therapy continues. There were other programs to which I saw very closely, which were to non-communicable diseases, like the programs, national program of in cancer, and then in diabetics, as well as cardiovascular diseases and strokes. And these programs were adopted by Government of India to bring a behavioral as well as the lifestyle change in the public, and creating an awareness about these diseases and showing that how lifestyle change can greatly affect and can reduce these diseases, even like strokes, cardiovascular diseases, diabetes, and the cancer. Aim obviously is to prevent the diseases and control the diseases as far these are concerned, as these affect the whole country and the population of India. Compliance of DOTS strategy under revised National TB Control Program, to which we nowadays call it as National Elimination TB Control Program, was very, very important. We all know that man basically is a defaulter. He defaults anything which you tell the person concerned until unless his behavior gets modified. Three words that probably one has to understand when we talk in terms of adherence. One is the compliance and adherence. Some people say these are synonyms. But while working in the field, we realized that these are two different words, compliance and adherence. Compliance is to carry out the instruction of your doctor. And it is a passive way to carry on. And we used to say that you have to change the behavior of the patient to act in a manner as the doctor wants. That means doctor gives him the information, tells him the information, and behavior gets changed so that his defaulter attitude really becomes one of the attitude of carrying out the orders of the doctor, the treatment which has been prescribed by him. We all know that there are certain diseases like tuberculosis, like diabetes, like hypertension, has long-term treatment, and if not taken regularly, the morbidity and mortality continue to rise. So is true as far TB is concerned, where if the drugs are not taken regularly in the prescribed way, then the chances of development of a drug resistance does occur. Therefore, compliance is one which I was talking about, that it is a passive way of taking the drugs, carrying out the orders of the doctor. Whereas the adherence is where patient participates in taking the drugs. And that is a dynamic process that is created between the doctor and the patient. And in fact, we say that doctor-patient relationship is one of the most important to ensure the adherence of the therapy as far as the patient is concerned. But adherence you just cannot achieve just like that by telling the patient. You have to tell him what are the chances of its side effects. You have to explain him about the disease. And also you have to explain him how and why he must take the therapy for such a long period. In fact, I used to take, frankly, whenever, you see, I'm a clinician throughout my life, and we used to take almost 30 to 40 minutes to guide the person first time when we used to write the therapy about tuberculosis. And we made a questionnaire, the motivation scale, we made it. And we tried to check him on the motivation scale, whether he is properly motivated to carry on the drugs, and he has understood why it should be taken for such a long period. And once we were confident that he had been thoroughly motivated, not only once on the day of the start of the treatment, but every time he was checked on the scale of motivation, whenever he used to come to visit us. This was before the DOTS strategy, but DOTS strategy changed completely the concept of treating the patients, where directly observed treatment was given to the patient, and the patient, but there were many difficulties that the patient has to visit the DOTS center every day, and elderly population, obviously it was very difficult for them to visit. So out-of-pocket expenditure usually rises when a patient of tuberculosis, whether young or females or elderly, come, because they come with 1 or 2 persons daily, at least for the first month of the treatment. And therefore, there were other methods were devised, which probably were very, very useful. You must have heard, most of you, 99 dots. What is this 99 dots? 99%, chances of persons taking treatment was created through NICSHE, where the people were given the drugs, they were told to take the therapy, and the day they take the therapy, they get some kind of a number which is combined with the number already given to them, and then they inform through telephone, through mobile, that they have taken the therapy. And it was found that 99% people really followed that concept. In other words, the newer techniques of treatment where compliance or the adherence could be ensured were devised, and still they are devising the ways and methods by which we can ensure that people can comply with the therapy. We also are aware that there are different ways by which we can find whether a person is compliant or he's not adhering to the therapy. By indirect methods as well as direct methods. Indirect methods, like when you interview the patient, you can ask him whether you have taken the therapy regularly or not. Or we ask him to bring the packet which has been given of the drugs to him. By counting the pills, you can make it. Or by providing him a questionnaire where he can tick mark whether he has taken the therapy or not. These are all indirect methods. And in fact, one of the questions which we used to ask to our TB patients, what was the color of the urine? We know all that rifampicin is the very important drug which is given practically in all patients of tuberculosis in the initial stage. And the color of the urine usually becomes a deep pale or red color. So we used to ask him whether the color of the urine was red or it was not red. But there are indirect methods are not very useful because sensitivity and specificity of complying the therapy was not very high. We had also seen, and I'm sure most of us have seen, that patients who are given the are admitted in the hospital, many times staff nurse thinks that the drugs has been taken by the patient. But we did see, we were rather surprised. Most of the times when we find patient is not improving, we started questioning the patient whether he has been taking the drugs or not. And you will be surprised that we found in our patients, many of the patients sometimes, that under the pillow, they were keeping some of the medicine. Because what is happening, the staff nurse is giving the drugs, asking the patient to take the therapy. But patients, they pick up the medicine, which is easily for them to be taken in, but they leave the drug, which probably had a bitter taste. And therefore, the complete therapy is not taken by the patients. Therefore, the compliance is a very, very complicated, process to which if one has really to work very hard to ensure the patient complies with the therapy. There is another aspect, that is the long persistence of the therapy. There are three words now: compliance of the therapy, adherence to the therapy, and third word, which is the persistence of the therapy. That is the duration for which the patient is to take the therapy, so that the mortality and the morbidity in that particular disease could be reduced. There are direct methods nowadays we are having by which we can see whether patient is complying the therapy or adhering to the therapy. Is the biological markers which can be measured, can be seen, but there the person has to give the blood, and not many patients really come forward. Similarly, tracer compounds can be measured, and also the biological assay of the body fluids can be done. So as the time is passing, we are finding newer and direct ways which have a very high sensitivity and specificity to find whether the person is having the drug regularly, is complying with the therapy, is adhering to the therapy, and whether he is continuously or persistently taking the therapy. Because these three areas are very, very important. So to see the success in the treatment of the patient, and at the end of the day, to the National TB Control Program, as well as the other programs, which is very, very important. Lifestyle change and behavioral change is the hallmarks of non-communicable diseases, which requires to be done. And changing a behavior of a person is not easy. It requires many sittings with the patient. For example, if you want to tell a person to stop smoking, I mean, you require a lot of effort to make a person to understand that. And we all know that tobacco clinics or smoking clinics have been run at many places. And where not only the doctor concerned, but the psychologist, counselor, and all those sit together to ensure that message goes to the patient. Similarly, the third part which I'm taking up is the elderly population, which find difficulty in compliance as well as adherence and persistence in the therapy, not only because the regimens which are given to the person are complicated, but also they are not suffering from one disease, but many diseases. Polytherapy is one of the reasons of not complying with the therapy and not adhering to the therapy. Side effects, risk factors, as well as side effects of the drugs is another factor which doesn't allow elderly to continue with the therapy. That is why the concept of DOTS provider for TB, and that way a drug provider, we can say, for the elderly came up, that if you want to treat an elderly patient, if you want that the compliance of the therapy in the elderly can continue, then you have to put one person responsible. In fact, family members have not been found to be very, very effective way of treating the elderly patient at home, because most of the time the younger generation is busy and they do not take care of the therapy as for the elderly population is required. And therefore, we always say a DOT provider from nearby house or their friend is the best person who can help in ensuring that compliance of the therapy can be continued. Well, dear friends, there are other important factors which really are very, very important. And I think healthcare practitioners need to understand factors for which contribute to the non-compliance. And they have to use effective methods to ensure that compliance of the therapy in elderly or in chronic diseases can be done effectively, so that you can not only reduce the chances of disease, but also you can reduce the other morbidities which particularly the elderly patient is suffering from. With these few words, ladies and gentlemen, it's a great pleasure for me to come and be part of this particular discussion and symposium which is going to be held. Thank you very much, ladies and gentlemen.
Thank you, sir. Thank you very much for your wonderful words. And this is very important to give emphasis on adherence. You had already give a very important introduction on that. And adherence, there is A for agreed upon on decision making. That means there should be an active participation from the patient end also. And you beautifully give emphasis on that. So now may I request our chairperson, next session's chairperson, Dr. Kaushik Ranjan Das, who is a consultant family physician and geriatrician in West Bengal, and he is the honorary president of Geriatric Society of India. And also may I call Dr. V.K. Arora sir, the emeritus director, NDTBC Delhi, to proceed for the next session. I am requesting Dr. Das sir to introduce our OP Sharma sir. Over to you, Dr. Das sir.
Please unmute yourself.
Thank you, Dr. Shamadar. This session is on drug prescribing in elderly. The speaker is none other than Dr. O.P. Sharma, who is National Professor of Geriatrics and also Senior Consultant Geriatrician in Innervation Apollo Hospital. He is the General Secretary of Geriatric Society of India and working for elderly care for more than 3-4 decades. 4 decades. We started in the 80s. 4 decades. So before giving to O.P. Sharma sir, I request Dr. V.K. Arora sir to request.
Okay, right. Thank you very much, Professor Ranjan Das. And it's a great pleasure, always to introduce Dr. O.P. Sharma, to whom I have a great association, and I have a great respect for this person. In fact, I salute every time, even though I am the patron of GSI, that is what we all say. And but I have a great respect and salute this man, his energy, his effort, he has practically given himself to the Geriatric Society of India, works day and night. And, he has brought this society to this level, And last time when I was introducing, and once again, sir, if you allow me to say that Dr. O.P. Sharma with his wife, both had been also contributing to the Prime Minister's fund during COVID times. So, he has a great heart, human heart. And his wife practically supporting this man. That is why it appears to me that he spends so much time on Geriatric Society of India. Thank you very much, Professor O.P. Sharma. We wish you long life, and we want to see you for many years to come and continue to guide the Geriatric Society of India. And I will now request Professor O.P. Sharma to come forward and give his lucid lecture, which I'm sure we are all going to enjoy, prescribing drugs for the elderly. Professor O.P. Sharma, the mic and the stage is yours.
Thank you so much, sir. First of all, I would like to lodge my complaint that my full introduction has not been given. My full introduction would have included a sentence that he's like a student of Professor P.S. Shankar and Professor V.K. Arora. And I feel so happy that these teachers have been guiding us at all places. So now let's start it. So respected chairpersons, Professor Arora sir, Dr. Krishna Ranjan Das sir, our past president, Madam Prabhadikari ji, Dr. J.K. Sharma, Dr. Rajesh Taneja, Dr. Dheeraj, Dr. Anand Ambali, Dr. Sir Sachin, Dr. Partha Rai from UK, Dr. Mangla Borkar, Smitha Kavle, and our Delhi's president, Dr. GPS Grewal. At the outset, I am grateful to both these associations for giving me this opportunity. May I share my slides, sir?
Definitely, sir.
So in next 15 minutes or so, which have been so generously granted to me, I'd like to justify the topic. As in the very beginning, Professor P.S. Shankar said that the success of the treatment will be if we prescribe the proper drug and the patient takes it. And then Dr. Arora made it the remark that unless there is a proper compliance, the effect also doesn't come up. Now, while coming to prescribing in elderly, there are four things. One is the drugs and elderly. Then comes that clinical pharmacokinetics and pharmacodynamics. That means what the drug is doing to the body and what the body is doing to the drug. And then drug knowledge and the compliance issues. And lastly, the prudent drug prescribing. These are the topics I'm going to touch, but I'll stick to the time. Well, friends, there are certain facts that the number of elderly is increasing day by day. And as a matter of fact, as a growing nation, we are really suffering because of the high number also, but can't help it. There are certain problems that elderly, they constitute a big percentage of it, and the elderly are prescribed a lot of drugs and they buy OTC drugs also. And there are certain facts that medicines play a crucial role in geriatric healthcare, no doubt about it. There are changes in PK/PD, which affect elderly because of the age and because of the various metabolic changes that occur in the body. There are a number of medications and number of risk-related issues that come up because of the polypharmacy also. And there are a lot of adverse drug events also as the days advance, and the quality drug again is an issue. Well, friends, large number of drugs are being added every year and off-label indications are increasing. People are buying from the counter, and there are a lot of pharma hike or marketing hype to the nutraceuticals also, but the elderly have a lot of comorbidities also. So they suffer because of the polypharmacies as well as polypathies. There are elderlies who might be taking allopathic medicine for something, homeopathic medicine for the other thing, and Ayurvedic for the third one. Nothing unusual. And as Professor Arora pointed out, compliance is always a big issue with them. So one has to keep in mind about the aging physiology and the drug therapy. And last but not the least, because most of the times it is paid from the pocket, so cost is always an issue. Friends, elderly purchase about 40% of the OTC drugs, no doubt about it, and the use is threefold higher. And nearly about 100 billion a year is being spent on herbal products also. I'm not against Ramdeji, but the way the things are being prescribed, the way the things are being brought out, a lot of elderly, after getting impressed from the television or from the advertisement, they start the drug without thinking or without consulting anybody. That's again an issue. We'll touch briefly upon the PK/PD. Well, friends, pharmacokinetics means what does the body to the drug, and pharmacodynamic means what drug does to the target. As far as kinetics are concerned, there are issues about the absorption, distribution, metabolism, and excretion. And as far as dynamics are concerned, there are two types of effects, the desirable and undesirable. We all know this in a simple way. We'll explain the whole thing, that there are issues about the absorption, which may be by mouth or by inhalation or by injection. And then there is, after the absorption, comes to the liver, metabolism, goes to the blood then goes to various issues, and finally may go for excretion also. For excretion, it is either through the feces or through urine, but there are a lot of drugs which are excreted through the saliva as well as. Here I would like to mention specifically that caffeine, phenytoin, and theophylline are excreted in saliva, which many of us forget. And the things excreted in the sweat also include salicylates and also alcohol. Now, friends, there is a free drug in the circulation, no doubt. There is an effect because of the absorption, biotransformation, elimination, and the target site availability, various tissue storages, fat, muscle, bone, etc. And their proportion changing with age, again making a difference. Then there is a binding of the drugs. In elderly, because of the low albumin, there may be issues. Because of the fat, there may be issues. Because of the water compartments, there may be issues. All these things are to be considered while prescribing a drug to the elderly. Unfortunately, a geriatrician has a lot of extra burden. Friends, the gastric pH affects, the gastric emptying affects, the splenic flow, the intestinal motility, everything affects. And constipation being quite a common problem in elderly, rather a subject in itself, as a big issue on the drugs. Similarly, there is a malnutrition, dentures issue, dietary restrictions, and unfortunately, the alcohol intake again has a lot of clinical implications. The fat mass increases, the body muscles come down, the total body water comes down, the albumin comes down, the alpha-1 glycoprotein comes down, goes up, and the heart failure increases. So these things also affect the pharmacokinetic changes in the drugs. Well, here we can see the amount of fat and the amount of muscle. You can see the difference between the elderly and the young person. Friends, there are certain aging effects, that is the decreased body water, increased body mass, increased fat, and the low serum proteins. They affect all these things because certain drugs may be hemophilic, certain drugs may have muscle binding, certain drugs may be lipophilic, and certain drugs may be unbound active drugs. So one has to remember all these examples. And while prescribing, just don't go by the information given to you by the pharma industry. Apply your brain, see your patient individually, and considering the effects of aging, please change your prescription accordingly. Well, as far as PK changes are concerned, there is a hepatic mass which comes down, the hepatic blood flow also comes down, and that is the reason that there are certain drugs like warfarin, benzodiazepines, and opiates which get affected. However, it's not that in every elderly, because of the liver, there are certain changes. There are certain drugs which has no effect because of the age, and ethanol is being one of them. Isoniazid is another one. But there are most of the drugs, their hepatic clearance is decreased because of the age, and I'm sure a number of them we prescribe day in, day out. Similarly, after the liver, the kidney is another important thing. The kidney mass comes down, kidney blood flow is being affected, the number of nephrons go down, GFR also go down. And in elderly, there is a term that we remember always, dynamic GFR. The GFR keeps on changing very frequently. So in these people, one has to be more careful. Don't go by the pharma cutoffs that SGLT can be used up to this eGFR, not in this EFR. So you are still safe. You may not be safe. So one has to remember the excretion of certain drugs, and drugs like cimetidine, digoxin, gentamicin. If you don't remember them, then you may land into the clinical side effects, which may occur even with their pharmacological doses. Friends, there are certain formulas to calculate the eGFR. They are all available on the net, but this is another issue in elderly, specifically for elderly, and there is a polypharmacy. They have number of drugs to be used because it is not the one system, the whole body is involved because of aging, and for every system one requires one pill. Now, there are a wide range of definitions for polypharmacy. There is no consensus definition. However, generally defined as administration of more medications may or may not be clinically indicated. So at times it is not the elderly who is at fault. At times it is we medical people who are at fault because we may prescribe more medicines which may be more than the medicines required by the patient. And mind you, try to limit your prescription to 4 drugs or so, because beyond that, as Professor Arora said, compliance becomes an issue. Now, ADRs, very common. The government is saying that report every ADR. There are sites for that, but in spite of that, ADRs are not being reported from India. As a matter of fact, we do a lot of work, but reporting and documentation is pretty poor with us. Now, there are 5 major categories with which WHO is concerned: unintended and undesired effects of the medication at a normal dose, means at a pharmacological dose. And the problems are adverse drug reactions, medication errors, therapeutic failures, drug withdrawals, and overdoses, out of which the most important is ADR. Well, polypharmacy increases with the age, so does ADR. Because more the number of drugs, more are the side effects. Now, ADRs, more than 2 million ADRs, and there are a lot of deaths because of that. And it is one of the leading cause of death. A lot of money is being spent on treatment of ADRs also. And I do remember distinctly while doing PG, one of our professors used to comment that, listen, more patients die because of our treatment rather than by avoiding our treatment. And at times he used to laugh and say, well, sometimes patients do recover in spite of our treatment. So friends, that comment, which looks like a joke, but it's a nasty comment. It's a nasty comment because we do not remember the side effect of the drugs. We do not keep our eyes open for checking the ADRs, for which we have to always consider the pharmacokinetics and pharmacodynamics of the drugs in elderly people. Then I think we will be a better prescriber. Now, a lot of hospital admissions are there because of the ADRs, no doubt about it. And out of those hospital admissions, majority are in elderly. Risk in 15% with two or more medication, risk increases as the number of medicines increase, and is maximum when there are more drugs. Now, it's a deadly cascade. There is an adverse event for which we give a drug, and then another problem occurs. So we give another drug. So because of one drug, you have to use more drugs to take care of the adverse effects of the medication. So best thing is to avoid, nip the evil in the bud. Now, avoid prescribing cascades. Means there are certain combinations that not be used. One should be careful. Hydrochlorothiazide and allopurinol. NSAIDs with antihypertensive. Metachlorpropamide with carbidopa or levodopa. And cholinesterase inhibitors and tolterodine. So friends, let us come to the practice of safe drug prescribing. And what is that? Let's follow certain criteria. And Beer's criteria is one which we follow day in, day out. What is a Beer's criteria? That high potential to cause severe adverse drug events. So there are certain drugs about which one has to be very, very careful. Amitriptyline we use day in, day out, 10 milligram, 25 milligram, 75 milligram at bedtime, very commonly used. Same are the antispasmodics. I've seen people ending up in the emergency ward, in the emergency area with acute intestinal obstruction because of the antispasmodic. And these are the 8 dynamic obstructions that occur, which require watching the patient for hours together or days together, and which requires a great patience in the surgeon as to not to operate. There is a high potential but less severe areas. These are the antihistaminics. I precisely remember I got a call from a member of parliament who was shouting because his wife was prescribed by an antihistaminic by one of the CGHS doctors, and the poor girl had not done any fault. She gave the antihistaminic, but this lady had an exaggerated response because of the antihistaminic. She was drowsy, she was not able to get up, and she had become incontinent. So I said, there's nothing wrong with the doctor, nothing wrong with the drug. The thing is wrong with your patient only. wait for some time, don't do anything. I mean, to the extent that he was prepared to call the police and create a scene. Similarly, there are certain new additions which are still under observation, and glibenclamide, sliding scale insulins. These are some things which we use, about which we still have to have more experience. There are certain combinations which are risky, like ACE inhibitors plus potassium, leading to hyperkalemia. ACE inhibitors plus potassium sparing diuretics, again hyperkalemia. Digoxin with antiarrhythmics, leading to bradycardia, very, very common. Digoxin plus diuretic, leading to electrolyte imbalance in elderly. This is something available on net. If anybody wants a copy of my lecture, please send me an email. I'll be happy to share my slides. Now, be aware of drug interactions. There are 100% chances of drug interactions with 8 drugs, and we have to be very, very careful about that. There are nearly 50% of the geriatric patients are on at least one of those 8 drugs. So you have to be very careful about the drug interactions. Again, there are certain combinations which are risky, like NSAIDs in CHF. Again, it's a problem. BPH with anticholinergic, leading to urinary retention. Dr. Taneja is watching. He is the right person to comment on that. Metformin in heart failure, again, creates a problem, but we all use it day in, day out. Now, NSAIDs plus gastropathy, again, becomes a big issue. So there are certain drugs which cause a stasis of the GI, and in that, the drugs which act particularly on the stomach, in such people, if you use normal doses of NSAIDs, you may land into trouble. Now, ageism may now be more persuasive than sexism or racism. Discrimination against a person on the basis of their age has serious consequences, no doubt. But being vigilant doesn't mean that we are being discriminated. So ageism can take many forms, including prejudice attitude. Well, our attitude is not prejudice, but our attitude is of care, and that is what a geriatrician does. Friends, there are certain drugs which have quick or exaggerated response. Please be careful in using them, particularly a small dose of diuretic, and the person becomes incontinent. Similarly, these are again the common drugs which we use day in, day out. Let's be particular about them. So my humble submission is, use the drugs in elderly, use them judiciously, try to remember their adverse side effects, try to remember their pharmacokinetics and pharmacodynamics, and if possible, be vigilant about watching the adverse effects. And if you are able to spot them early, it is always good, because you will be able to save the admission, you will be able to save the patient, you will be able to save the extra use of drugs to take care of those adverse side effects. Thank you very much.
Thank you very much, Professor O.P. Sharma, for your very lucid lecture. I said right in the beginning, we are going to hear you and hear something different. Thank you very much for this. And we all know polypharmacy is one thing which probably elderly are subjected to. But this is within our power when we prescribe to see at least the interaction of the drugs doesn't occur. And we should be alert to quickly find any ADR which occurs because of the therapy. Sometimes polytherapy becomes necessary because of multiple diseases or multi-system involvement. But nevertheless, an alert physician will always ensure that he does not give the drugs unnecessarily. Many times we have seen people are prescribed B complex, 2 types of B complex, vitamin D, 2 types of vitamin D. See, these kind of unnecessary drugs in the prescriptions from the general physician can be day out, day night seen. One must try, it may be polypharmacy, but reduce the therapy as much as you can when you are treating and prescribing to an elderly. with these words, I will request other faculty and stalwarts who are sitting to take part in the discussion. If they have any question, comment, well, they can raise their hand and we can always invite them for any comment or any question.
Sir, there is no question in the chat box, sir.
Okay.
I have seen the chat box. There is no question in the chat box.
Okay, okay. Then the mic is yours.
So is there anyone in the...
Yes. Dr. Prabha Adhikari wants something. Dr. Prabha, you want?
Slides. Very good slides.
Yeah.
So I want his slides.
Yeah, everybody will like to have your slide. Don't wait for
no question from you. You should rather be, you being a professor of geriatric medicine, you should rather guide us. Thank you.
How can she guide to the national professor in geriatrics, dear friend? Anyway, it's good to hear you. Yeah.
Yes, sir. So we can move to the next session, sir. We are running short of time. So over to Dr. Shambhu.
So let me come in. I am Professor
Yes,
Shantanu Tripathi, because the next talk is by Dr. Shambhu, Shamrat Samazdar. So I was requested to really welcome Dr. Shambhu, who is the next speaker, and he will be actually talking on elderly health and preventive medicine. And I have the privilege to welcome Dr. Prabha Adhikari, who is a professor and head of geriatric medicine at Urinary Medical College. And she is also the immediate past president of Geriatric Society of India. Welcome you, madam. I have the privilege to welcome you. And also I request Dr. Anand P. Ambali, who is the Professor of Medicine, Geriatric Clinic, BLDEDU, Sri B.M. Patil Medical College and RC, Vijayapura in Karnataka. Welcome, Dr. Anand Ambali.
Thank you, sir.
Both of you have to act as the chairpersons for the next session, and the speaker is Dr. Shambhu Shamrat Samazdar. So over to you, chairpersons, respected chairpersons. Over. Thank you.
It is my pleasure to introduce Dr. Shambhu Shamrat Samazdar, whom you have seen, the young enthusiastic person that he is. He's a general physician, diabetologist, and general practitioner in Kolkata, has an experience of 7 years in these fields. He practices at Health ETC Clinic in Kolkata. He completed MBBS from RGKar Medical College in 2010 and MD Medicine from Utkal University in 2016. And he's currently doing DM in clinical pharmacology. What a great person he is. He is at the moment in Calcutta School of Tropical Medicine. Some of the services provided by the doctor are diabetes management, clinical pharmacology consultation, prescription safety assessment, prescription reconciliation, asthma and allergy management, allergen immunotherapy. So over to you. I think this entire workshop is because of him, and we are very eager to hear him and request him to share his knowledge with us.
No, madam, first, thank you, madam. It is a really honor because you were one of the dreamed speaker, I may say. Whenever you talk in different conferences, I was eagerly hearing you. So it is a really honor for me. But I had not done my MD in medicine. I have done my MD in pharmacology from Utkal University, and I had completed my DM in clinical pharmacology, and now posted in School of Tropical Medicine. So thank you, madam. Thank you very much. And at the onset, I just want to thank Dr. Kaushik Das, Professor O.P. Sharma sir, and Professor Shantanu Kumar Tripathi sir for giving me this opportunity to share my voice with this august audience and galaxy of speakers. So in this diagram, you can see that incident when Horatius set out to defend the Roman bridge against the Etruscans. He knew full well that the city elders had already planned to cut it down, sacrificing him and the bridge in order to save the day. So chronic disease care in the older person in many ways is like a Horatian bridge and often present in the background, requiring much attention but getting little care, and in the moment of crisis easily sacrificed. So in this cartoon you can see the diagram of, or you can say the photograph of Ida Killing, Roger Gentleholm, and Don Pellman. All of them has one similar feature, that they are 100 years old. They are active. What is important to note that the protagonist of modern medicine must highlight that there are two techniques to manage disease in the geriatric population. Number one, acknowledge its presence, and number two, we need to prevent it from developing in the that disease. That means what we are going to discuss for next 15 minutes. So the latter leads us on the preventive medicine that we are going to discuss now. But what happens if we are talking about preventive medicines, specifically in the field of geriatric medicine? The geriatricians and other physicians caring for the older person must see whether there is the role of preventive medicine in the older person also, because there are some argument against that. So with that, and as we know that the preventive medicine in the field of elder people is often neglected, but this COVID-19 vaccination program is one of the, we can say, torch bearer in the field of this geriatric preventive medicine. And we all know that the geriatric population was giving more emphasis while choosing vaccine against COVID-19. So with that, we are going to discuss about this topic. So what is the loss of health with aging? So in this chart, we can see the representation of normative aging with loss of full stock of health. So what is full stock of health? That means when the individuals are born, and that indicating the no morbidity. So when there is a, if we can contrast with that squared curve with that convex curve, so we can find the difference. So what we want fuller stock of health, and for that we need to square that particular curve, and that represents the ideal situations for most patients. And for that, these 5 important mantras are there to have squared curve against that curved curve. So don't smoke, be physically active, eat a healthy diet, maintain a healthy weight, and get enough sleep. There are some concerning numbers in India we can found. Populations more than 60 years, as we know that the geriatric population or elderly population generally denoted the age if it is more than 60 years. But there are some debates also on that issue. But it is tripled in last 50 years. Even if we can see the census data of 2001 to 2011, there is almost 1% increase in that population level whose age is more than 60 years. The problem is that 88% of them are confined to their home or bed. 27% of them who are more than 80 years are homebound. And important thing is that the economy, per capita expenditure on health among them is at around 125 rupees. This is 2005 data. So now you can assume the increment in that, but I found no data on that in recent days. This is 2005 data. And at that time, what is important, the per capita out of pocket expenditure was at around 100 rupees. And among that, maximum was the outpatient expenditure, that is 74 rupees. And most of that outpatient expenditure is contributed by purchasing drugs. So that is 72 rupees. And it was assumed that due to this increasing cost, there is a chance that 40% of this population will go below the poverty line. And unfortunately, among this elderly population whose age is more than 60 years, among them 73% are illiterate as per that 2011 census data. So what types of prevention we know from our community medicine classes? We need primary prevention when disease does not occur. We need secondary prevention to detect and treat asymptomatic disease before symptoms occurs. And then the tertiary prevention, that means the consequences of existing disease and recurrent disease that should not occur, like stroke prevention or something else. So now coming to the primary prevention, we need to promote health habits. We need to increase adherence on these important broad headings. We need to maintain nutrition, again counsel against smoking or alcohol. We need to promote exercise, adequate sleep, immunization, specifically in regards to pneumococcal and influenza vaccination, prevention of osteoporosis. Need to see the predisposing factors which are modifiable, like smoking, obesity, hypertension, diabetes, hyperlipidemia, and hypercholesterolemia. Non-modifiable risk factors, we don't have any control over that. We need to check how to prevent injury. Examples are prevention of burn accidents, falls, removal of obstacles, keep the floor dry, bright lighting, flat shoes, like low-level switches, easy and safe access to water, like that. Regarding secondary prevention, to early detect the disease and having the prompt intervention, we need to have a very good screening program. We need to screen for early detection of modifiable risk factors, and subsequently we need adequate management, specifically diseases, chronic diseases like hypertension, diabetes mellitus, dental problems, drug adverse effects, cancers, infections, nutritional deficiency states, and eye and ENT checkups. So early detection of and treatment is an important step of this secondary prevention. So there are few important points that follows by United States medical program when the age is between 45 to 64 years. So here another question arises, whether the preventive approach we should start after 60 or far before that. So when we are checking a patient whose age is 40 years or maybe 35 years, 36 years, from that time we should think how they should take some approaches so that they can prevent the geriatric diseases. Apart from that, if we go by that United States Task Force recommendations, then we will find They consider prostate cancer screening with annual PSA and digital rectal examination at age 50, beginning of colorectal cancer screening at age 50 with fecal occult blood testing or flexible sigmoidoscopy or colonoscopy. There are a variety of pharmacoeconomic study also done there, and that suggests generally to do occult blood testing in community level and flexible sigmoidoscopy or colonoscopy in very high risk level. Otherwise, the cost will be much more. Reassess the vaccination status and accordingly need to plan vaccination against these infections like influenza, streptococcus pneumoniae, tetanus, or viral hepatitis, and also need to consider screening for coronary artery disease. Now, when the age is more than 65 years, what should be the approach for this? Or what should be the preventive approach? Number one, again, we need to readdress the smoking status and encourage cessation at every visit. Smoking cessation program, there should be there. This is not that much common in our country, but it was very much recommended there to do one-time ultrasound at least for abdominal aortic aneurysm in men whose age is 65 to 75 years who have ever smoked. Need to check PFT for all long-term smokers to assess the development of COPD, vaccination against influenza and pneumonia, screen all postmenopausal women for osteoporosis, reassess the vaccination status. So reassessment is very important. Screen for dementia, depression, visual and hearing problems. So there are some specific screening tests that can increase in life expectancy for a whole population. So there are some examples of that, like mammography, pap smears, screening like TMT for asymptomatic patients. Again, there are newer evidences generating which giving this type of test, screening test, little bit in backdated, but this type of study, or at least we should also have to get more convincing data in our populations. So getting a 35-year-old smoker to quit smoking, that can increase the life expectancy for a population by 3 to 5 years. So that is why already we had discussed whether the preventive approach of these geriatric diseases should we start little bit earlier than what we are discussing today. So beginning regular exercise for a 40-year man, that means 30 minutes for 3 times a week, that increase the life expectancy of a whole population by 9 months to 2 years. Now coming to the tertiary prevention, that means it deals with the rehabilitation and caregiver support. And this is a multidisciplinary approach which includes physician, physiotherapist, occupational therapist, psychiatrist, dietitian, nurse, and social worker. Now coming to the adherence, which is very important, and this is one of the very serious threat because there are lots of drugs we are using for prevention, like statin. So we can see if we have a study in our country also, we'll get lots of data on this non-adherence. Apart from that, that is opposite to the adherence. If we are taking some drug which is not actually prescribed by us, very often we see our patients are taking pantoprazole, domperidone combination drugs, pantoprazole, itopride combination drug, or lesuride combination drugs for a long time. And we all know the consequence of this type of therapy, specifically when the patients are elderly. So importance of medicine adherence is there, as the elderly are prone to multiple comorbidities and they suffer from polypharmacy. there is an increased chance of non-adherence, and non-adherence leads to decreased therapeutic benefit, frequent hospital and physician visit, increased healthcare expenditure, and sometimes cause over-treatment. And there is a direct link with that cost and non-adherence. So cost-related medication non-adherence, that due to the cost skip dose, reduced dose, or delay or not fill a prescription. I am not taking statin because in my prescription, I am taking some costly anti-diabetes drug. So this is something we need to consider. And we need to take action when there is some cost-related medication non-adherence, and we can search for low-cost prescription, low-cost alternative, generic medicines. So interventions such as medication therapy management, considering the cost-related medication non-adherence issues in older adults is very important. Lastly, which is very core to my own topic, own discipline, that is clinical pharmacology. I am a student of clinical pharmacology. So preventing atrogenic injury in elderly, it was beautifully elaborated by Professor O.P. Sharma sir. So I am just giving one example of my, So a real life case, that is 88-year-old lady, hypertension, COPD, and hypothyroid. So she presented to orthopedic surgeon with a low back pain, and you can see the prescribed FDCs, which were gabapentin 400 milligram per plus nortriptyline 10 milligram. So she had also taking pregabalin 75 milligram plus nortriptyline 10 milligram, but it was not disclosed to that orthopedic surgeon. She was continuing that also together, along with aceclofenac paracetamol, deflazacort 6 milligram, along with pantoprazole. Now what happened? All after taking 5 days of this type of medicines, she had some complaints of GERD-like thing, along with dryness of mouth. So went visit to one gastroenterologist, and that gastroenterologist prescribed a FDC of pantoprazole plus itopride. Patient was taking ondansetron 8 milligram due to the vomiting from over-the-counter drugs, and also taking domperidone on top of that. Along with, she had some cough, so took azithromycin 500 milligram once daily. Again, that is over-the-counter. Now what happened? The patient visited to hospitals, medical college hospitals, medicine department with 3 episodes of palpitation with blackout. Now, as there is so many medicine, that particular patient was referred to clinical pharmacology OPD of School of Tropical Medicine, where we were there, and we took a detailed medication history, and we had done one ECG, and that ECG suggests a QTC prolongation. So prolonged QT was there. So now we can assume that why this patient was suffering from this type of palpitation and blackout. So from our OPD, the prescription was reconciled. We omitted all those anticholinergic drugs. And after 1 month, the patient came back to us with no symptoms. So this is what Professor O.P. Sharma was beautifully mentioned, the importance of prescribing cascade, and we need to prevent that. And when there is polypharmacy, there is always increasing chance of prescribing cascades. And this is the cartoon we can see, the prescribing cascade. If I am taking one drug that causing some symptoms, and to control that symptoms, I am taking another drug, and for that again some symptoms is happening. We are not understanding that the drug is the etiology, and this cycle, this vicious cycle is going on and on. So this we need to prevent. So there are some specific issues while prescribing drugs in elderly, and these are the important points. First of all, the elderly are clinical trial orphan, and maximum drugs that we used in elderly are off-label drug. And already we had discussed about that physiology changes that happen to the patients while they are elderly, the altered pharmacokinetic, pharmacodynamic properties, multiple comorbidities, multiple medicine systems, Ayurvedic systems, so on, and adherence issues, medication issues. So we need to consider this all while seeing our geriatric patients. And this was an important scale that can prevent drug-induced injury. Just if we can see our own case that we discussed, that 88-year-old lady, the patient was taking nortriptyline 20 milligram. So you can see the anticholinergic burden. It is not only like that, I am taking some specific anticholinergic drug and I will have anticholinergic side effects. Not like that. Even some drugs which is not actually belonging to anticholinergic group, they have some inherent property of anticholinergism. And this is one chart when we can see the drugs like doxepin, or we can say flavoxate, commonly prescribed in elderly population also when they are suffering from UTI. The ACV score is high, 3. And if a patient is taking 2 or more this type of high score drug, they have high chance to develop anticholinergic side effects. So we need to understand this very well. Apart from that, we also can predict whether this patient is going to develop adverse drug reactions by different types of score. And this is a very easy score, Geronto net ATR score. Like if a patient has comorbid conditions 4 or more, the score is 1. Congestive heart failure, then 1. Liver disease with transaminase level more than 2 times of upper limit of normal, then it is 1. If there is no other number of drugs less than 5, then it is 0. If it is between 5 to 7, it is 1. And number of drugs is 8 or more, then the score becomes 4. Previous history of adverse drug reaction, score is 2. There is some compromised kidney function, eGFR less than 60, then it is 1. But again, there are some drawbacks to this particular score also. From this great podium, I request the pillars of Geriatric Society of India and the geriatric physicians to plan for a development of a score that should be India specific. I request all of the respected doctors today present to guide us to develop one ADR predictive score which can help our Indian patients. With that, I want to thank you all. And this was a quote by Thomas Edison that the doctor of the future will give no medication, but will interest his patients in the care of human frame, diet, in the cause and prevention of disease. I still remember one presentation, extraordinary presentation by Prabha ma'am on exercise, importance of exercise. And exercise, yoga has no other alternative. And we need to percolate this message to everyone. With that, I thank you all. And this is one picture taken in our clinical pharmacology OPD at School of Tropical Medicine. It was pre-COVID era. It was around 2018 and time. So with that, I thank you, and over to our respected chairperson, madams.
Excellent deliberation and my appreciation. Really, it was a scholarly lecture, I would say, and I'm very, very happy I got to chair this session. I have great respect for pharmacologists, especially clinical pharmacologists, because we in KMC had created a clinical pharmacology unit where pharmacologists came to the ward with us and educated us. So that was a fantastic exercise that we were having, and you have shown it by your presentation. And I'm sure I'm going to consult you for many of our polypharmacy cases, especially our near and dear ones.
Thank you,
over
madam.
to Dr. Anand Ambali for comments and questions.
Yes, madam, that was a very lucid presentation. And the message was very clear that if do no good, at least do not harm. That what we follow in as a clinician. So let the session is open for questions from the audience.
I saw Dr. Dheeraj Kapoor, I think, raising his hand sometime during presentation.
We don't have questions in the chat box, but if anybody wish to ask the question, they can put it in the chat box. We can.
And I think GSI should take the suggestion from him in developing the Indian ADR risk score.
Yes,
he should lead us, being the DM
madam,
pharmacologist.
you will guide us.
Yes.
We need this development of this score, and this is.
Yeah, I think we will develop
badly.
Yeah, with people like you, I'm sure we'll be able to develop. Yeah.
Well, our past president has also said it is to be done means it is to be done. And what I assure you, Madam past president, that GSI will join hands with them, will make a small team and try to do it.
Yes.
As far as the financing part is concerned, GSI will take care, but we will involve them as our resource personnel. Thank you for your suggestion.
Can I make a comment here?
Yeah, please.
I am Professor Shantanu Tripathi. I superannuated from School of Tropical Medicine as head of clinical pharmacology. And I have the privilege to start this clinical pharmacology OPD outpatient clinic at School of Tropical Medicine, which is the first of its kind in the country. We are now trying to start the clinical pharmacology OPD as well as the consultation services in one of the premier private hospital in Kolkata. And I'm happy that we have Dr. Shambhu with us, who is a very good, I should say, learner in this area. And he is an asset in the area of clinical pharmacology. I just make a couple of comments. The first part of his presentation was, or rather the title of his presentation was Preventive Medicine. I would say when you talk of drug-induced disorders in the aged, prevention is certainly better than cure. And second, about the preventive medicine in the elderly healthcare considerations should commence perhaps much earlier than the commencement of the elderly age. If we want our elderly people to live healthy, then perhaps we have to start thinking from, say, the age of 45 or 50. So geriatric medicine, practice of geriatric medicine, not only to welcome people after they have attained an elderly age, rather they should encourage, and I hope the society will try to promote this concept, that if you wish to have a healthier aged life, come to us when you are approaching in the middle of your 40s, then only you can expect. So I would say the principle of catch them young, if you wish to offer the elderly individuals a healthy life. And the third, I would say, regarding that drug-induced disorders, the best prescription is one that perhaps does not contain any medicine. With these few words, thanking Dr. Shambhu Samrat Samajdar profusely, I wish there is a huge future of clinical pharmacology in geriatric practice. And I wish the society will foster this and work together with us. Thank you very much. Over.
Thank you, sir. So with all of your
excuse me.
Yes, sir. Yes, sir.
I want to disclose one thing here. Our Professor Shantanu Tripathi sir, Shambhu Samrat Samajdar, and other 4 persons, all are members of Geriatric Society of India. They are our members. This is my
yes. Thank you very much, sir.
Thank you, sir. Thank you. So we are moving to our next.
There are few questions in chat box. I think if you can attend, just check one ADR. And can the Beers criteria be used for reporting ADR? So please clarify, sir.
Sir, with your permission, can I write down that answers, because our next speakers are already present and we are
Sure, sir.
by
Please, sir. Please write
time,
down.
so we can move forward with the next session and we will answer those questions in the chat box.
Fine, sir. Fine. Thank you, sir.
Thank you, madam, and thank you, sir. So now we are moving to our next topic, and to introduce a speaker and topic, may I request two eminent personalities from Geriatric Society of India, Professor Sandeep Tamanne, who is the consultant physician and geriatrician in the Dinonath Mangeshkar Hospital and RC Pune, Maharashtra, and our own Professor Jyotirmoy Pal sir, who is the Professor of Medicine, Archikor Medical College, and Dean of Indian College of Physicians, and he's a pioneer in the field of medicine, research, and education. Over to our respected chairperson, sirs, to introduce our honorable speaker and the topic. Over to you, sir.
Thank you, Dr. Shambhu, for inviting me in such a occasion. Topic is elderly bone health and adherence to care services. And speaker needs no introduction. He is not only. Am I audible? Hello.
Yes, sir. Yes, sir. You are audible, sir.
আমার কথা শোনা যাচ্ছে?
হ্যাঁ স্যার, শোনা যাচ্ছে স্যার।
আচ্ছা আচ্ছা। Speaker Professor Sujoy Ghosh, not only well known in the field of endocrinology or diabetes, in every field of medicine, starting from medicine to geriatric medicine, Sujoy Ghosh needs no introduction. He is now Professor of Endocrinology of RPG Modern SSKM Hospital. He is the National Honorary Secretary of Endocrine Society of India. He is the National Joint Secretary RSSDI. He is the National Joint Secretary of Indian Thyroid Society. He has more than 200 publications in his field, and he is the author of more than 100 books. And recently, he achieved what you know everything. There is the best physician there is the third of this kind in this country from the American Society of Endocrinology. So I request Professor Sujoy Ghosh, please start your deliberation.
Thank you, Jyotirmoy, for that kind introduction, and thank you, respected chairpersons, and thank you to Geriatric Society of India and organizers for having given me this wonderful opportunity to speak. And I have been asked to talk about elderly bone health with a little bit of twist on adherence to cares and advices. Now, bone health is a very, very big issue, particularly in the elderly. And if you look at the prevalence of osteoporotic fractures, you can see that it is very, very high. And if you compare it with other disorders which affect the elderly population, you can see fractures are probably much more common than most of the other problems that the elderly suffer from. Now, why is fracture so very important? Because, you know, if somebody has a hip fracture, the median survival was about 2.5 years. And the 1-year mortality of a hip fracture is actually equal to or slightly greater than having an acute myocardial infarction. Now, having an acute myocardial infarction, everybody in the family of that individual is worried, is concerned, and so is the patient. But, you know, when it comes to preventing a hip fracture, probably people do not realize the morbidity and the mortality associated with hip fracture. A study from Northern India shows that the annual incidence rate of hip fracture is pretty high in individuals above the age of 55, and 15 to 20% of Indians above the age of 50 have evidence of vertebral fractures. And if you look at both Dinesh Dhanwal's study as well as Raman Marwa's study, you can see that as an individual ages, the risk of having any fracture, either the hip or the vertebral, increases dramatically. Particularly after the 7th decade, you can see the risk goes on increasing dramatically. And we were talking about, you know, costs of therapy. The cost, of course, varies where you're getting the patient treated, but the minimum cost of a hip fracture would be anywhere around 1.5 lakh to 2.5 lakhs in private facilities, or in the public facilities would be at least 50,000 rupees. And if you look at the Indian data, the data seems pretty bad. Particularly studies conducted from ICMR in southern India have shown that Indians in general have bad bone mineral density compared to our Western counterpart, and that there is a very high prevalence of osteoporosis and osteoporotic fractures of the spine and the hip, whether you're using the Hologic database or the ICMR database. To make matters worse, apart from osteoporosis, a study from PGI Chandigarh shows that there is a very high prevalence of osteomalacia in the elderly, which essentially compounds the problem because on one hand, you have got poor protein matrix of the bone, and on the other hand, you've got very poor mineralization of the bone. And once an individual suffers from a major fracture, the mortality increases, the risk of having a second fracture increases, and there's limitation of activity, including increased health issues. Postural changes may also, of course, limit activities, limit social and economic abilities, and of course, vertebral fractures are also associated with several other problems. Psychosocial implications of fractures can also be great, including loss of self-dependence. Now, bone health in elderly is very important, particularly because of undernutrition, because of reduced mobility, and with age, there's loss of muscle mass and sarcopenia, increased fragility, and we were talking about the ill effects of smoking and alcoholism. Hypogonadism is again a major problem in the elderly, which compounds the bone problem. And then there are several comorbidities that the individual has, which makes treatment even more difficult. And in the elderly, there's an increased risk of fall, which essentially means that the risk of fracture increases. And several drugs that we keep on using, particularly in the elderly, increase the risk of bone problems. And if you look at the bone problems that we are talking about, the commonest, of course, is osteoporosis and osteoporosis-related fractures, but osteomalacia, vitamin deficiency, and hyperparathyroidism also are very common, just as chronic kidney disease-related bone diseases are. So this is just in a summary to try and figure out the interplay between nutrition, body composition, physical activity, aging, and the changes in the body hormones, which all lead to poor bone mass. And if you look at the common identifiable risk factors for fracture, of course, increasing age, women are at greater risk, individuals who particularly are frail, those who are tobacco users, individuals who have low body weight, early menopause, poor calcium intake, excess alcohol intake, poor vision, increased risk of fall, minimum weight bearing exercises, and multiple medical conditions and drugs, which can actually increase the risk of having a fracture. And by definition, the definition of osteoporosis is based on a bone mineral density study. Now, this itself is flawed because, a bone mineral density actually does not clearly categorize an individual to have risk of osteoporosis. It just looks at the amount of bone or mineral in the bone rather than actually tell us how likely is a fracture to happen in that individual. But we still keep on using BMDs by DEXA as one of the measures of assessing the risk of fractures and bone mineral density. And we know as an individual ages, the BMD keeps on changing. And more than the bone, we need other tools to tell us who is at a risk of having a fracture. And we usually tend to use a fracture risk assessment tool, or the FRAX. We now have Indian data in the FRAX as well. These are people living in Singapore from which Indian data has been derived, which looks at several factors, including previous history of fractures, parental history of fracture, and multiple drugs. And FRAX probably is better than the use of only a BMD. There are also osteoporosis self-assessment charts, which are less commonly used. And what should probably be done, maybe look at the height of the individual annually to check whether there's loss of height, because that could be a measure of vertebral fractures. Bone mineral density should be checked in all individuals after a particular age. And I believe that age should probably be anywhere between 50 to 55 years, unlike the Western guidelines. Vertebral fracture assessment can be done with the BMD machine itself, and also look for secondary causes of osteoporosis. All of the other bits here are mostly of research interest, except perhaps trabecular bone score, which is now being more commonly used in clinical parlance. Still, even with the fracks, we realize that there are several things that are not assessed, including the risk of falls, because the risk of fall depends on a lot of things, including the eyesight, the muscle strength, the ability to walk, accompanying medical illnesses, medication, and of course, the environment in which the individual lives. And there are several other measures to assess falls, which the geriatricians are quite conversant with, which should probably be used to supplement the results found from the fracks. The secondary causes of osteoporosis and other bone problems have to be looked at depending on the clinical presentation. Reassess the nutrition of the individual, because that's something that goes wrong terribly, particularly in countries like India, looking at calcium, vitamin D, and protein intake in an individual. Vitamin D deficiency is almost universal in India. More than 90% of India's population is probably vitamin D deficient. What a paradox for a country with so much of sunshine. And if you look at the steps of management, of course, nutritional supplementation and counseling are going to be important. Exercise training, weight-bearing exercises, prevention of falls, and potentially modifying secondary factors, and of course, pharmacotherapy. Now, in terms of the dietary requirement, in most of our elderly population, we would need to give somewhere around 1200 milligrams of calcium and anywhere between 600 to 800 international units of vitamin D, and at least 1 gram per kilogram body weight of protein requirement. That's what most of the international bodies would talk about as well. In terms of the exercise, mobility might be an issue, but try and mobilize the individual as much as possible, particularly if possible with weight-bearing exercises and muscle strengthening exercises is important. And if possible, at least 5 days a week, if not at least 3 sessions a week are recommended. Prevention of fall, vitamin D repletion and physical activity and weight-bearing exercise is very important for that. Correction of visual impairment, attention to gait instability and gait training. Make sure that the home environment is safe. You probably need an occupational therapist to actually come over and have a look. Hip protectors are actually of no use in clinical practice. The other measures, try and reduce sodium intake, cut down the amount of coffee intake, cessation of tobacco, limiting alcohol intake, drug surveillance, and where required, hormone replacement therapy. Now, I'm not going to talk about the individual pharmacotherapies because that itself could be a big topic itself. But remember that the 3 main drugs that we are using currently, apart from the calcium supplementation, the vitamin D, and the hormone replacement therapy where needed, is bisphosphonate, which acts for preventing further decline in bone mineral density, teriparatide, which we are using as an anabolic agent, and also denosumab. So these are the 3 agents which we are commonly using in clinical practice. And because we are going to try and talk about ways and means in which we can ensure adherence and compliance, we have to keep on asking the patient for compliance, particularly if there's a caregiver who's looking after the patient. We've got to keep on assessing. Assess risk factors and lifestyle modification should be done. Serial BMDs could be useful to make sure that the patient is actually doing well. And one of the things that we now have is biochemical markers of bone resorption markers and bone formation markers. Now, that could be used intelligently in 2 ways. One, to try and make sure that the patient is actually responding to therapy. And secondly, to make sure that the patient is actually adhering to therapy. So both could be assessed by making sure that the bone markers are measured, say, at 3-monthly interval, because the BMD takes at least a year or 2 to actually improve. A multidisciplinary approach for bone problems is essential. The leader of that could be the geriatrician, the endocrinologist, the primary care physician. The physical medicine guy is very important because he has to actually help with the mobility, the exercise. The orthopedic surgeon would be important if the individual sustains fracture or needs corrective surgery. Vision needs to be improved by the ophthalmologist. The dietitian needs to help to modify the diet. Neurologist is also important. And of course, you need a counselor or educator. And if you look at the various studies that are there in terms of looking at adherence and non-persistence of therapy of osteoporosis, this is a study from the Netherlands, which says, where the healthcare facilities are free, and yet at 1 year, you look at the compliance of the osteoporotic therapy, particularly the bisphosphonate, is appalling. And this is predominantly because either Individuals do not appreciate how important it is to prevent fractures, particularly hip fractures. Secondly, is because of the side effects of taking a bisphosphonate. So you've got to explain to the patient carefully how to take the drug with a glass full of water, sit upright so that there is no reflux and there is no esophagitis. And if you look at adherence to osteoporosis regime among men and analyze the individuals who probably have secondary osteoporosis or people who already have other medical illnesses or even a major fracture, they are more likely to adhere to therapy rather than the ones in whom you're trying to go for a primary prevention of a fracture. So re-educating the patient about the problems of non-adherence have to be highlighted. If you look at differences in adherence to osteoporosis regimes, you will see people will adhere to certain therapies better than others. For example, raloxifene and calcitonin, people are not going to adhere to. Whereas if you're going to give a drug like alendronate, which is once a week, the individual is more likely to adhere to that therapy. So trying to cut down the number of tablets, the frequency of medication might also be actually useful. So if we are actually wanting to overcome problems with adherence, we actually have to improve patient education. We have to ensure that the healthcare provider is actually talking to the patient, discussing with the patient, highlighting the importance of treatment and prevention of problems, and taking into account the patient's preference as well, and also ensuring that the drug that you're giving is not causing extra side effects. That's something very important. And again, we were discussing about pharmacoeconomics. So, there's no point in asking a patient to take a drug which is going to cost, say, somewhere around 8,000 rupees a month if he cannot afford it. So you've got to be sensitive about the price of the medication that you are using in managing the particular problem. So there could be several strategies to maximize adherence. Of course, long-term adherence is poor for any therapy which is chronic. The key to adherence would be to actually talk to the patient and explain to the patient. Counseling is important. Enlisting the support of the patient's social network is important. You could send reminders to the patient for follow-up appointments and even the follow-up drugs, addressing patients' concern regarding side effects, encouraging and providing a patient-friendly relationships, and non-physicians, healthcare professionals really play a very, very big role. And some of the things that we could do is re-educate regarding drugs and the way to take them. Pillboxes could help, and we could even go for supervised therapy. And instead of, say, weekly bisphosphonate therapy, you could go for once a year zoledronic single shot therapy. Instead of daily teriparatide therapy, you could go for once in 6 monthly denosumab therapy. Instead of once monthly vitamin D supplementation, you could go for once yearly vitamin D injections. And like I said, you could go for bone markers to ensure that there is adherence to therapy. Now, we realize that if you have one fracture, you're more likely to have more fractures. And usually individuals who have a major fracture like a hip fracture usually have a preceding fracture, which we call a sentinel fracture. So it's important that if an individual has a fracture, a fragility fracture, that you aggressively treat that individual. And if you look at individuals who've already had one fracture, look at the proportion who are not at all treated and not even being prevented from having a bigger, worse hip fracture. So one of the things that's become very common in the Western world and also in countries like India, we ourselves in our corporate hospital have started one of these services, which is a fracture liaison service. So there's a non-medical individual at the center of a fracture liaison service. So every patient that comes to the hospital with a fragility fracture, whether it's at the emergency, whether it's with the orthopods or whether it's in the outpatient clinic, this particular individual is intimated about it, who actually starts the fracture liaison service, wherein multiple individuals get involved and an integrated service care is provided to this individual, which actually helps. So there's a toolbox or a toolkit to provide the comprehensive fragility care. There's a standardized management process, there's a standard care plan, there are checklists, and the fracture liaison service officer actually helps run this service. So that's the kind of flow pathway of a fracture liaison service, which actually helps better patient education, better awareness, and better adherence to therapy, because of the multiple inputs that are provided to the patient for the service. So you have the fracture liaison service, the chain, the fracture nurse, the coordinator, and the case manager there. There are still challenges to maintain a sustainable fracture liaison service, which at least I have not been able to set up at IPGMER, my teaching institute, because we don't have that kind of IT support. We don't have a dedicated individual. And because there are so many multiple professionals involved, that it becomes difficult to actually keep track of that. But, of course, in the corporate hospital where I work, this is something of a reality, and you can monitor non-pharmacological interventions and, of course, demonstrate long-term benefits. So I shall finish by summarizing again to say that in the elderly, bone health is a serious issue. Bone health can be impaired in a number of ways. Lifestyle measures play a vital role. Pharmacotherapy, when applied, should be followed up. For compliance, rehabilitative services should be consulted time to time, and fracture liaison services is the need of the day. Thank you very much.
Thank you, Professor Ghosh, for very comprehensive review of bone health in elderly, especially discussing osteoporosis and fragility fractures, mainly discussing the preventive measures, which are really very, very important and often ignored by busy physicians like us. Two observations, an excellent talk, very lucid. I have worked in UK, and you talked about hip protectors, and you mentioned that they are not of much use, which I also agree, because at one time there was a lot of discussion about hip protectors, and everybody, every elderly was advised to use hip protector to prevent hip fracture. Obviously, there were problems with that, and slowly that particular discussion faded away. And second thing, you mentioned about fracture liaison service. In UK, we used to have orthogeriatric services. And I remember about 25 years ago when I worked in UK in teaching hospitals, I worked as an orthogeriatrician, and it really worked well. All the patients with orthopedic problems, medical problems, we discussed about their medical issues like diabetes, heart disease, hypertension, in addition to dealing with osteoporosis, falls prevention, etc. So I think the excellent talk, and the session is open for questions. Anybody?
May I speak? See, it's not a question, just a comment about pharmacoeconomic. And I think that's a very important part which he talked of, Dr. Suzoi talked of. And I think if we are not ensuring compliance in a patient, it's not pharmacoeconomics of the individual which gets affected. It has a cascade kind of an effect. And the whole healthcare gets compressed because of the extra expenditure that occur at the national level. Therefore, I think it's very important that we may ensure that we should reduce the number of drugs as far as possible. This is comment number one. Comment number two is to reduce the number of pills. We, in fact, in National TB Control Program or National Elimination TB Control Program, we have started fixed dose combination, Even though, see, in the earlier, we had a doubt that fixed dose combinations may not be good. We may give individual drugs to the patient. But later on, many studies prove that fixed dose combinations are equally effective. And it also increases the compliance of the patient. Persistence has been always a problem in these patients, but nevertheless, compliance of the therapy, because the doses and the frequency gets reduced to a greater extent. I think these were the two comments I wanted to give. Thanks very much, Suzoi. It was a nice lecture.
Thank you, Arora sir. Professor Adhikari madam has written a comment about COVID and health, bone health. Professor Ghosh, would you like to comment on that? Have you observed any bone health problems in elderly, specifically during the current COVID endemic? Right. Is there anything specific you would like to tell us?
I think what Dr. Prabha is trying to actually highlight is about the indiscriminate use of steroids that has probably happened in a significant proportion of the population. Now, we've got to remember that bone abnormalities following steroid therapy will not be reflected in DEXA scans, because what happens is probably changes in trabecular bone scores, which we usually do not see on a regular basis. And BMDs, in terms of the BMD changes, that's going to take ages. And the structural abnormalities in bone that happens almost immediately after the start of steroid therapy. Because we are not looking at such structural studies, we are looking at the barn door DEXA scans. we usually do not pick up any abnormalities on the DEXA. That's number one. Number two, anybody who is on steroids for more than 2 weeks, particularly in doses greater than 20 to 40 milligrams of prednisolone or its equivalent, are going to be at a risk of having fractures and bone health problem. Unfortunately, what we don't tend to do in such situation is we don't start alendronate, because we should probably be preempting that if we are going to use the steroids for more than 3 weeks, we should start alendronate at that point of time itself. Most of the time what happens is people have had steroids for a long period of time, and then some doctor, retrospectively asks, oh, you've been on steroids for 3 months or for 2 months. By that time, the beneficial effect that would have happened with the initial starting of the bisphosphonate no longer happens. So, what harm we have done to our elderly population with the steroids, we'll get to know more of it as time goes.
Professor Ghosh,
may I make a comment, Sandeep?
Yes, sir, yes, sir, carry on, sir.
Well, I must say it was a wonderful talk. I was just reminded of a study which was done 35 years ago in school-going girls who were swimmers in Israel, and there they found the effects on their bones, which were detected but not detected by the BMDs. So they started altogether a different concept, in which here now what we are doing, basically there is a matrix which is made, which is nothing but protein fiber. Embedded in that are the calcium crystals being facilitated by vitamin D. They went a step further, and there they found that it's only a pharma high of calcium and vitamin D that is being stressed upon. That is not the complete bone care. There's a lot of role of the protein, there is a lot of role of the exercise, there is a lot of role of anabolic steroids, there is a lot of role of the androgens as well. And I do remember I was invited in the year 2009 in US in one of the anti-aging conference, and the topic was bone health, when to intervene. So I think the intervention should start before the conception, as a matter of fact. Like as we start screening, moment I see Dr. J.K. Sharma on the screen, I remember that there is a thyroid screening being done, even in the couples, in whom if one of them is hypothyroid, then they keep on monitoring the child also. So similarly, about the osteoporosis, if there is a history among the parents, then when such people get married, they have to be careful, and at some age they do develop. There is a lot of role of the androgens, there is a lot of role of anabolic hormones. And I think this only calcium and vitamin doesn't make a difference. Unfortunately, even at corporate hospital, we also see patients dropping in with high serum calciums who have been prescribed injection vitamin D 6 lakhs units injudiciously, weekly or bi-weekly or once in a fortnight or things like that, and that has created problems. So I think it's a very important topic. And one of the reasons in COVID was the immobilization of elderly rather than the use of the steroids. That was one of the editorials I read in one of the articles. Thank you.
Professor Ghosh, what's your opinion on calcitonin nasal spray for osteoporosis? Is it still used? Or?
I think it is abused. I wouldn't say it's used. There's absolutely no role of nasal calcitonin. And the only thing that we were taught in our pharmacology days was it has got some mild analgesic effect, which also goes away after the first couple of days. So let us not use calcitonin for osteoporosis at all, period.
I totally agree with Sujoy. The nasal calcitonin use is very, very effective if there is a pain in the back and osteoporosis also. So it's more of a painkiller, but that too, the effect is short acting. My experience has not been very good with that either. Thank you.
Okay. Any other questions from the participants? If there are no questions, I think we'll end the session. Thank you very much, Professor Ghosh. Excellent talk. We learned a lot from it, and we hope to listen to you in our future conferences also. Thank you very much.
Thank you, sir. Thank you, Professor Sujoy Ghosh, sir, and our respected chairpersons, Professor Jyotirmoy Pal, sir, and Professor Shondeep Tamanya, sir. So now we are moving to our
I think something wrong. It got stuck up.
Hello?
I think slides got stuck up.
It has become constipation.
Yeah.
Dr. Shambhu, are you there?
Hello. Yes, I'm there.
Dr. Shambhu?
Hello?
Hello.
Okay. Dr. Shambhu Samrat Samazdar.
Yeah, sorry, sir. I was disconnected due to some technical glitch.
Okay. Now go on. Yeah.
Okay. So I'm very sorry for that. There is some network issue in my area now. So there is one announcement that Professor Biman Kanti Roy, who was the next speaker, is absent due to some issue. So we are fortunate to have Dr. Shambadipto Das, who is his student. He's the postdoctoral training. He had done his MD in internal medicine, now doing his DM in neurology under Professor Biman Kanti Roy, sir. So for that, I request our respected chairperson for this session, Professor P.S. Shankar, sir, to introduce this topic to all of us. Along with that, we have Professor Rajesh Taneja, who is a senior consultant urology, andrology, and robotic surgery from Indraprastho Apollo Hospital, New Delhi. So I request both of the chairpersons, respected chairperson, to introduce this topic, and we can go forward with this, Dr. Shambadipto Das. Over to chairperson, sir.
Friends, when we think of good health, we should have a good appetite, good bowel movements, and also we should have periodical widening of the urine. So then only we say we are healthy. All these systems are functioning properly. So when there is any difficulty, either in passing the urine, or there is a frequency of urine, or there is a constipation, or even diarrhea. So as a matter of fact, so then we say that we are not keeping well. There's something wrong. And this particular thing happens in elderly persons very frequently. Many of them will come with complaints of loss of appetite, or constipation, or frequency of the urine, drinking of the urine, or not passing the urine. So all these complaints are quite often they come in the hospital or any private clinic also. So the person, when we say good health, we should have a good bowel movement. So one person said that what is the most important achievement you had is that I had a very good bowel movement. So that's how people will appreciate about this normal passage of the stools. So elderly persons are quite often afflicted by these two complaints, bowel and the bladder. So they have to function properly. And now today, we have the Shishya of Dr. Das, because yesterday only we had celebrated the Guru Purnima. So it is a tribute to the Guru. So his disciple has come to give the lecture. I really welcome him and I request him to deliver his talk. Thank you.
Thank you, sir. Good evening, respected faculties and the learned audience. I am Dr. Shambadipto Das, junior resident in Bangalore Institute of Neurosciences. Today, I will be speaking on this topic of bowel and bladder care in elderly and adherence issues on behalf of my mentor, Professor Biman Kanti Roy. So, urinary incontinence, it is an important and disabling symptom in the older age. It can affect about 20 to 30% of this elderly people, And why is it so disabling? It is because of its social as well as the physical impact that it has on the patient. Socially, it can lead to depression, social isolation, and physically, the most important part, it can lead to increased risk of fall, while along with resultant injury, while the patient is rushing to the toilet for incontinence or issues like that. So before we go into details or dive into details of this topic, let's have a quick recap of the functional neuroanatomy and neurophysiology of micturition. So the process of micturition, it involves a complex neuronal circuit. It involves the brainstem, brain, and the spinal cord from above, along with the local urinary tract innervation, which is occurring locally. The key players in the urinary bladder which are involved, this includes the detrusor muscle and the sphincters, the internal and the external urethral sphincters. So whenever this detrusor muscle is relaxing and the sphincters are contracting, it is feeding of the bladder that is going on. And whenever there is contraction of this detrusor muscles along with relaxation of the sphincters, this is when the voiding phase is occurring. So about the little local neurological innervation, this detrusor muscles and the sphincters, they are supplied by the parasympathetic, the sympathetic systems, along with somatic neurons in the form of pudendal nerve. This pudendal nerve, it supplies the external urethral sphincter, which is under the voluntary control, and this sympathetic and parasympathetic nervous system, this supplies the detrusor and the internal urethral sphincters, which is not exactly under our voluntary control. So where do this parasympathetic supply comes from? It usually comes from the intermediolateral tract of this S1 to S4. And while the sympathetic, it comes from the T11 to L2 spinal segments, and it goes by the hypogastric nerve and supplies this detrusor as well as the internal urethral sphincter. To add to that, the efferent system goes on from the bladder and goes back to this parasympathetic and the sympathetic system in this spinal segments, and it is carried by the A delta myelinated fibers. It is important to note that in health, this A delta fibers, it is carrying this impulse from the bladder. But in case of ill health, when there is a spinal cord disorder, this A delta fibers, they become incapacitated, and it is the unmyelinated C fibers which carry these bladder sensations and lead to symptoms of urinary voiding. Now going to the higher centers, in the pons, there is this Pontine micturition center. The Pontine micturition center is actually responsible for creating this synergy between this detrusor and this external urethral sphincter, so that whenever the one contracts, the other relaxes, and not that the both will contract at the same time, so that there is dyssynergia. And even in the higher center, in the cerebral cortex, the predominant supply that we get is the anteromedial frontal cortex. Along with thalamus and hypothalamus, this anteromedial frontal cortex, it has inhibitory influence on this Pontine micturition center that we are talking about. And the facilitatory effect of this Pontine micturition center on the local bladder system, this is inhibited by this higher center till a socially appropriate situation or a socially appropriate place is found where we can micture it. So let's get into the details of how this structures, if affected, will cause this urinary symptoms. So we divide the symptoms of a urinary bladder predominantly into two forms. Either there is a symptoms related to urinary storage, or there is symptoms related to urinary voiding. Storage is predominantly the increase in frequency, urgency, urge incontinence, while urine voiding abnormalities, it is predominantly seen in the form of hesitancy, precipitancy, increased residual volume after micturition, and these things. So when there is a suprapontine lesion, that is, we are talking about when the higher centers are affected. Commonly in the elder age, there could be a frontal lobe as well, there could be an NPH, there could be a multi-infarct state, there could be a dementia, most importantly, there could be Parkinsonism and MSA. All of this can lead to this affection of this suprapontine area. So what happens if the suprapontine area is affected? The inhibitory control of the cortex over the bladder, it is lost, And there is detrusor hyperreflexia. And this will lead to predominantly the storage symptoms, that is the frequency, urgency, and the urge incontinence. Just going a little downwards, in the spinal lesion that is occurring from this Pontine maturation center to this suprasacral area, about in the S2, between this area, if there is a damage, the Pontine maturation center, it was helping in this detrusor and the sphincter synergy. That is, the both of them should not be contracting in the same time. So this part is lost. Besides that, there is also loss of this supracortical, the cortical control. So there is also detrusor hyperreflexia. Detrusor hyperreflexia, it will lead to the storage symptoms that we were already getting in case of suprapontine lesion, and there will be associated voiding symptoms because of this loss of PMC control, that is the Pontine maturation center control, and there will be detrusor sphincter dysynergia, which will be manifested predominantly in the form of hesitancy. The patient will have difficulty in initiating the urine while he goes to bathroom. And in case of, and the common lesions that can be affected in case of an old age could be a cervical spondylotic myelopathy, could be a collapsed intervertebral disc, which can lead to this compression and lead to this stoppage of connection between the Pontine maturation center and the local bladder neuronal contacts. And the last level of lesion will be an infraspinal lesion that is affecting the local bladder circuit, the parasympathetic and the sympathetic system, along with plus minus there could be involvement of the pudendal nerve. So what will happen in this case? It will lead to this element type of bladder. That is, there will be overflow incontinence, there will be dribbling along with that, there could be stress incontinence. Along with that, if the sensory arc is preserved, it will be very painful initially. And these are predominantly the voiding symptoms. And again, we can see in older age, there can be LS radiculopathy and collapsed intervertebral disc, which can also lead to this compression of this sacral fibers. Along with that, there could be spinal cord tumors. Along with that, there could be pelvic surgery, and all of this can lead to this infraspinal lesion, which will lead to this element type of bladder, which is underactive, and there will be predominantly the voiding symptoms. Now, quickly getting into the topic, as we age, there is multitude of changes in this lower urinary tract, both in the ultrastructural level as well as in the functional level. And this will again lead to storage as well as voiding symptoms. To add to that, there will be increased chances of UTI, probably due to this local structural changes. Along with that, there is altered immune function in older age. So all of this is going to increase the risk of UTI. And additionally, there are alteration in neurotransmission, both at central and peripheral levels as the age goes on. All of these are going to lead to this urinary symptoms. Urinary incontinence is probably very disabling in this older age. And the most common type that we find beyond 50 years of age is the mixed type. The patients usually have both urge as well as stress incontinence. However, while we evaluate these patients, the symptoms of urinary incontinence are often not revealed by the patients. That is a difficulty. So probably due to embarrassment or fear. So there is a simple assessment tool. There is a 3 incontinence question assessment tool that we can use. And this is quite sensitive in bringing out the type as well as the incontinence in case of elderly. So during evaluation of a incontinence in a geriatric patient, we have to rely on a very focused history as well as targeted physical examination. And this should be supplemented by urine analysis and post-void residual determination to help us to identify if there is any possible reversible cause which is responsible for the symptom in the patient. Our primary aim should be this reversible causes, which we can intervene and help the patient accordingly. This could include lower urinary tract conditions like in UTI, atrophic vaginitis, which can be adequately managed with an antibiotics or even a topical estrogen. There could be conditions where there is increased urinary productions like metabolic conditions with hyperglycemia in type 2 diabetes mellitus. It could be due to incipient heart failure where there is a fluid overload state. It could be due to impaired ability or willingness of the patient to reach the toilet. This is where the neurology comes in. The patient could be delirious. There could be chronic illness or injury, which is impairing the mobility. There could be psychological causes, as in case of an FTD, frontotemporal dementia. And lastly, the most important aspect, which we find very commonly, is there can be presence of offending drugs, which the patient is already using, which is causing this incontinent symptoms. Like there could be use of diuretics, there could be use of anticholinergics, there could be use of psychotropic drugs, which is quite commonly used, like an SSRI, tricyclic antidepressants, or there could be use of alpha adrenergic blockers or agonists. So our primary aim or the target should be to find these reversible causes. However, there will be scenarios where we won't get some reversible cause. In such cases, the recommendation is to have a comprehensive approach with the multidisciplinary systems involving the urology, gynecology, as well as urodynamic experts. So in the management of this urinary incontinence, if there is a reversible cause, we treat it accordingly. If there is not, there has to be some interventions. It would the recommendations include lifestyle modification in the form of low intensity physical exercise, as well as behavioral interventions in the form of timed voiding or double voiding. This is to avoid the residual urine, along with pelvic floor exercise training, which is very useful in case of female. Along with that, there is environmental manipulation and catheterization, like in case of we use the urinal, the bedside commode, along with incontinence undergarment or pads. Along with that, if these are not sufficing, we have to use catheterization, which can be intermittent, or it can be chronic indwelling catheterization when the risk and discomfort of urinary retention is quite high compared to the risk of a chronic indwelling catheterization. In such cases, we have to do that. And beyond that, if still there are the symptoms are difficult to control, we have to use medications. The two commonly used are antimuscarinic agents and the beta-3 agonists. That is, they're going to act on the detrusor and the internal urinary sphincters. However, the most important thing that we need to consider while considering for a drug therapy is that there will be anticholinergic side effects for that. And there could be cognitive decline in an already compromised individual with decreased cerebrovascular reserve. So such things must be considered while prescribing the drugs. Along with that, there will be polypharmacy and pill burden to these patients, along with complexity of the medical regime. And if this therapies also fail, then we need to go to surgical intervention. That is a multidisciplinary approach again, which can be better addressed with a urologist and a gynecologist if required. This is overall the gist how we actually manage a patient with a urinary incontinence. Now going on to the bowel issues in elderly. The predominant complaints that a patient gets disabled with are constipations, fecal impaction, as well as fecal incontinence. Fecal incontinence is quite high. In case of a hospitalized patient, it could range from 2 to 15%. Regarding constipation, what we as a neurologist we should usually think about is it could be a very important non-motor symptoms in case of a Parkinson's disease. This can be a very early clue and will help us to pick up the disease in a very early stage, and this might be helpful. Besides that, there is multitude of causes which can cause constipation in case of elderly, which needs to be addressed more comprehensively. The neuroaxis controlling the defecation is quite similar to the bladder pathway. I'm not going into the details of it. However, incontinence, it can occur if there is any structural or any functional defects in the lower bladder pathway, predominantly in the form of dysfunction of the anal sphincters, the external or the internal anal sphincters, or it can be a problem in the functional, it can be a functional problem also, like in the form of a abnormal rectal compliance or sensation, which we commonly see in case of a neurological disorders like a diabetes mellitus in a later stage, Parkinsonism, spinal cord injury due to any compressive etiology that can be seen in the elderly. And along with that, another important cause is altered stool consistency, like fecal impaction, which can lead to constant inhibition of this internal anal sphincter tone, and there will be incontinence around this impaction. And this is quite a common and reversible cause, which can be readily done if perceived. The bowel care in elderly, it involves this bowel habit training, the defecation training, along with lifestyle modification, toilet strategies, and drugs. The recommendation includes, there is strong recommendation for engaging in low intensity activity for about 30 to 60 minutes, 3 times a week, along with adequate fluid intake. Along with that, fiber intake has also great role. However, it is conditional, because fibers can exacerbate the incontinence in case of conditions where there is decreased rectal compliance. So we should be careful about that. Bowel training will be timing the bowel movements properly and adjusting the diet and sleep accordingly. Along with that, we should also do the pelvic floor muscle exercises, which will also be going to be helpful. Drugs, regarding drugs, we should consider about bulking agents like psyllium, especially in case of where there is low volume and loose stool. This is a condition where this is going to be quite helpful. Along with that, we can use the anti-diarrheal agents where the diarrhea is causing the incontinence. Predominantly, loperamide is used as the first line. After that, if there is further need, we can use bismuth subsalicylate or a polystyramine accordingly. Along with that, if I again will emphasize that if there is fecal impaction, disimpaction will definitely cause improvement in this bowel incontinence. So we should be careful about that too. Thank you.
Hello.
Hello.
Hello. Am I audible?
Yeah, you are audible, Dr. Taneja.
Hello. Thank you very much, Dr. Das. I really enjoyed your presentation for several reasons. So as a urologist, I must tell you that I see so many elderly people who are suffering from incontinence of urine. That's how they reach me. And the first thing is that they have seen so many physicians and everybody has started them on Urimax, thinking that it is a prostate issue. So that is the first tragedy that I need to point out. The second is that when they come to us and then when we evaluate clinically, if there is a central cause of incontinence, when I say central, it means whether it is the anteromedial part of the frontal cortex or the gray matter in the paraventricular area where there would be some infarcts, or there would be infarcts in the brainstem area, or some demyelinating disease of the spine. The problem is that they do not have a stroke. They do not have a history of stroke where there is a paralysis, but they do have a history of headaches. They do have a history of fear of fall. When they have a fear of fall, you ask the relatives, they say, does he want to go out? They say, no, he does not want to come out of his bed because he's afraid to fall. And then we know that, yes, this incontinence is because of a central lesion. The tragedy is compounded when I sent them for a MRI of the brain. The MRI brain says age-related ischemic changes of the brain noted. And with that, they go to some physician who says this is normal. So this is not the cause of incontinence. So I'm glad that it is coming from a neurologist. And I will suggest the organizers of this meeting to highlight this lecture to everybody, including the neurology fraternity, because it is sometimes extremely difficult. I send them to the neurologist and he comes back and says, "Unhone kaha, this is not because of any neurology issue. There is nothing in neurology. MRI is clear." So MRI is actually not clear. There is a report which says multiple ischemic infarcts in the brain which are related to age. So I don't know why they should call it normal. There has to be, brain has, so every part of brain has been made by nature to do some certain work. If it is missing, that the work suffers, actually. There is nothing additional. So I'm very glad that you pointed out these facts. And that is the first step. The second is when we finally see these patients for incontinence, regarding adherence of treatment, you rightly mentioned they are given anticholinergics. So there are 2-3 issues with the anticholinergics. One, of course, that they cross the blood-brain barrier and they can have a bad cognitive effect. The patient will forget. There are people who have forgotten their path back to their homes because of this reason. This has never happened, but they landed up in the marketplace and forgot what to do, and they came back somehow. So these are the issues that we have faced practically, these elderly people who have been given anticholinergics. So my suggestion is that if somebody has to give anticholinergics, we need to choose anticholinergics which do not cross the blood-brain barrier. So there are 2 types of anticholinergics. One is the trospium bromide, which is a quaternary compound. It does not cross the blood-brain barrier. So that is one, trospium chloride. The other is darifenacin. So darifenacin, though, can cross blood-brain barrier, it does not cross to the extent which causes the other. So it's a very small, negligible amount which crosses the blood-brain barrier. So for elderly anticholinergic drugs, trospium chloride and darifenacin. Now the tragedy is that these patients who are incontinent because of a central nervous system reason, you give something which is expected to work on the detrusor. As you rightly mentioned, anticholinergics will work to suppress the detrusor contraction. But here the problem is not detrusor contraction. The problem is the lack of inhibition from the prefrontal cortex, the anteromedial lip of the cortex, which actually suppresses the pontine center and allows the person to go to a particular place which is socially acceptable to pass urine. So that inhibition is gone. So pontine becomes liberated from the influence of the anteromedial cortex of the brain, cerebral cortex. And that is the tragedy. So you give an anticholinergic to this person. One, it does not act because the defect is not in the detrusor. It may cause some advantage, but certainly the effect is not as good. So people keep running from one urologist to another. They keep changing the anticholinergic. Somebody will increase the anticholinergic beyond the pharmacological window and end up with severe constipation and fecal impaction, which patients did not have to begin with. So this is how the therapies can go haywire when we are treating incontinence in these people. You touched a very important point, that was Parkinsonism. Now, Parkinsonism causes rigidity of skeletal muscles. So the perineal diaphragm is also skeletal muscle. The external sphincter is also a skeletal muscle. So there is rigidity due to Parkinsonism. Now, there are people who will come with obstructed urination due to the rigidity of the external sphincter not being relaxing, and they are subjected to TURP because these people obviously have some enlargement of prostate or not. So obstructive symptoms can be caused by Parkinsonism per se. Now you give Syndopa, which has anticholinergic effect. So Syndopa will relax the skeletal sphincter, but also reduce the tone of the detrusor muscle because of its anticholinergic effect. And that is what happens. So there's an increased residual urine, which is interpreted by urologist as obstruction. So he goes ahead and does a TURP, and the results are poor. So you have the disease which is causing obstructive symptoms, and then you have the treatment of the disease which is causing obstructive symptoms. And both these things compound with actual BPH. So a good urologist has to spend time to differentiate which of these patients should be actually operated and others should be left behind without surgery, because you just have to manipulate the medication. I think I have taken too much of time, but I must thank Dr. O.P. Sharma and the organizers of this meeting to have brought me here. And it was a pleasure listening to you, Dr. Das.
Sir, one question.
Yes.
Mr. Chairperson, sir, can I ask a question?
Sure, sure.
Yes, sir.
I'm aware of Dr. Taneja's interest in the bladder, and he is the only Indian who has been chairperson of the European Interstitial Cystitis Society, if I remember correctly. And I
Yes,
did,
sir.
and I also had the pleasure of seeing your book. My only question to you is, sir, that a number of times in elderly, when we ask for some MRI, the report comes multiple small lacunar infarct. In which specific area these multiple lacunar infarcts will matter the urinary bladder?
Yes, sir. So I'm speaking while we have Dr. Das, who is a neurologist here. But yes, with my little experience as a urologist, I can tell you that it is the anteromedial. If there is an infarct in the anterior lobe of the cerebral cortex and the anteromedial part of the frontal lobe actually, and subfrontal cortex, and then the paraventricular gray matter. These are the areas from where the inhibitory tracts pass towards the pons and they inhibit the Pontine center. And if there is a damage in these areas, which it is invariably, then one should think of a centrally mediated incontinence of urine. And giving anticholinergics will not work.
Thank you. Thank you so much.
I would wait for Dr. Das's comment, our speaker.
So you absolutely correctly said it. The pathway from the frontal circuit goes along and it converges into the Pontine maturation center. And then it passes through the spinal cord along the autonomic fibers, which is predominantly central and lateral, and then to the peripheral part of the peripheral nervous system of the bladder. So it was absolutely correctly pointed out, sir.
Thank you.
Thank you so much. I think it's time to give a big clap to the speaker and the chairpersons.
Thank you. Thank you very much. Thanks a lot. Because now OP Sharma's lecture is there, so we have to give room for him.
Not OP Sharma, sir, JK Sharma.
Thank you all. Thank you. So we are now moving to our next topic. There is some echo coming from someone's account. I think we, apart from speaker and chairperson, we need to mute ourselves. And I request our respected chairpersons also muting themselves while a speaker is presenting. Otherwise, some echo is coming. So now we are moving to our next topic, that is on treatment adherence in elderly diabetics. And for that, it is our really honor to introduce you all to respected Dr. Dheeraj Kapoor, who is the head of endocrinology from Artemis Hospital, Gurugram. He will be the chairperson of this session. Along with, may I request Professor Shantanu Munshi, who is the current head of Department of Clinical Pharmacology from School of Tropical Medicine. And we have speaker to this session. May I request our chairperson, sir, to introduce our speaker, respected Dr. J.K. Sharma, sir. So over to chairperson, sir.
Dr. Munshi, would you do the honors?
So I think there is some technical glitch from his side. So may I request you to start?
Yeah, so I don't have Dr. Sharma's slides, but let me tell you, he's less of a senior colleague and more of a family. Dr. Sharma, sir, has many accolades to his credit. He's a senior diabetologist in Delhi. He is the executive member of RSSDI. He is FRCP from all the 4 colleges, London, Edinburgh, Glasgow, and Ireland. I have been fortunate enough to co-edit 2 monographs with him for the Epicon, and sir has been benevolent enough to edit 1 section of my book, Diabetes in Pregnancy. Sir has also been a vice president of GSI, and of course, he has had many orations to his credit. Now, without much ado, I would request Dr. J.K. Sharma, sir, for his deliberation.
Thank you, Dr. Dheeraj. I'm extremely thankful to you for these nice words. And First of all, I pay my regards to Dr. P.S. Shankar sir, Dr. O.P. Sharma sir, Dr. V.K. Arora sir, and my heartfelt thanks to Dr. Kaushik Ranjan Das, GSI, and the other association with whom we are doing this CMA this evening. And the topic allotted to me is the treatment adherence in elderly diabetics. So I will be talking in front of my friend, the endocrinologist, Dr. Dheeraj Kapoor, who is a master in this subject of diabetes, and the geriatricians, the senior geriatricians and the professors of geriatric medicine, not only in India, but having their name in abroad also. So this is a test for me, but I think I'll try to do justice to the subjects. So first of all, I will tell you what adherence means. As per the WHO, the adherence to therapy is defined as the extent to which a person's behavior in taking medication, following a diet, and or executing lifestyle changes corresponds with agreed recommendations from a healthcare provider. So we have to take into account all these factors. Now, directly coming to the non-adherence, the various causes are multiple or complex regimes. Especially I'm talking about the elderly people, and that too in diabetes, fear of weight gain, hypoglycemia, and other associated adverse reactions of the drugs, poor or infrequent communication with the healthcare provider. In elderly, if you communicate properly, if you give time to the patient, listen to the patient, many of the problems of adherence are taken care of. Then, of course, the cost of therapy is very, very important. What are the resources? How the person has the economic status? How are the fundings? So that is very, very important. We may have many good drugs, but if you prescribe and the patient cannot afford, then there is no use. And then there is the perceived lack of efficacy as well. Now, complexity of dosing regimes, we all know that as the number of drugs increases, the adherence declines. And considering diabetes as the chronic progressive disease, the complexity of the medication regime is likely to increase over time. Multifactorial medication for diabetes and related complications can involve up to 10 tablets per day, and which is a very, very high number. Safety and tolerability, again, non-adherence could also be due to adverse events associated with medications, both oral and injectables. One of them is weight gain and the hypoglycemia, which is very important, which happens to be common treatment-related adverse events. And regarding hypoglycemia and the hypoglycemia unawareness in the elderly people, long-standing diabetes leads to diabetic cardiac autonomic dysfunction or cardiac autonomic neuropathy, which may lead to postural hypotension. And these patients, as we have just listened to Dr. Das, that these patients may also have associated neurological problems. So, in relation to diabetic autonomic, cardiac autonomic neuropathy, we have to look what other medicines are there which may lead to postural hypotension, leading to fall, leading to fracture, and in otherwise frail patient, elderly patient, if there is a fracture, then we have to really think of what will be the outcome. The older patients, they have less perception of hypoglycemia, as I have told you, owing to cognitive decline, which we can very well see here, the middle-aged compared to the older adults. Now, cost, and again, the economic considerations. In lower income groups, the cost of medication can be a reason for lack of adherence. The poor adherence can be significantly associated with financial difficulties, especially in our country, as well number of social factors such as taking the medication alone, a need for information, and lack of family or the social support to the patient. New agents may be preferred to older agents for a variety of reasons, but cost could prove to be a major obstacle in achieving the optimal adherence. As I told you, we may have a very good number of good drugs, but if the cost is high, then our patient may not afford it. The additional risk factors in older diabetic patients, the cardiovascular autonomic neuropathy, which is less recognized and understood complication of diabetes, despite its significant negative impact on survival and quality of life in people with diabetes. The frequent degenerative complication in diabetics, particularly in the elderly. The male elderly diabetic patients are believed to have a high potential of developing the benign prostatic hyperplasia or the lower urinary tract symptoms due to diabetes-related insulin resistance and hyperglycemia. So these factors these are the additional risk factors which we have to look into the older diabetic patients, and therefore achieving optimal glycemic targets by adhering to the treatment becomes vital in elderly diabetics. And that is how the targets for A1C are changed in our diabetic patients. The perception of medication, the perception of efficacy in terms of treatment can also have a significant effect on adherence. For example, common perceptions associated with both insulin naive and newly prescribed insulin patients. Number one is inconvenience. Patients have injection phobia. There is a good chance of hypoglycemia and less flexibility in the system. So simplification of medication dosing improves adherence, which we can see here. Once daily, adherence is better as compared to twice daily, 3 times a day, and 4 times a day. So simplification of the medication is very, very important in our elderly diabetic patients. And the non-adherence is also associated with significantly higher rate of hospitalization and mortality than the adherence, which we can see here. This is the rate, all-cause hospitalization. This is all-cause mortality, which we can see here clearly. Now, the clinical consequences of poor adherence. The main consequences of poor adherence in diabetes treatment is decreased glycemic control, or we can say the time in range, leading to the known complication of diabetes, including microvascular and macrovascular diseases. If the time in range is deranged by 70%, the retinopathy risk increases by 64%. The time in range is the time during which the patient should be in the euglycemic stage. That is, the normal is around 70%. So if there is a derangement of time in range by 10%, the retinopathy risk increases by 64%, nephropathy risk increases by 40%, and the neuropathy risk increases by 25%. Now, addressing the known adherence and implication of the therapy. Adherence. Usually patients presenting with type 2 diabetes are initially encouraged to maintain a healthy diet and exercise regime, followed by early medication that generally includes one or more oral hypoglycemic agents, and later an injectable treatment which may be needed. The A1C target, which I was telling you, usually is most adults with type 1 or type 2 diabetes, it is 7 or less than 7. But in adults with type 2 diabetes, to risk of CKD, reduce the risk of CKD and retinopathy. If at low risk of hypoglycemia, if the patient has a high risk of hypoglycemia, then the A1C target will be slightly on the higher side. But if there is a low risk of hypoglycemia, then it can be 6.5 or even lower. But in functionally dependent patients, elderly patients, it is 7.1 to 8%. And 7.1 to 8.5% if there is recurrent severe hypoglycemia and or hypoglycemia unawareness, limited life expectancy, and frail elderly with or without dementia, then this HbA1c target even increases up to 8.5. Avoid higher A1C to minimize the risk of symptomatic hyperglycemia and acute and chronic complications. And in end-of-life care, A1C measurement is not recommended. Avoid symptomatic hyperglycemia and any hypoglycemia. So this is how the A1C targets are changed in our elderly diabetics. Now, there is a checklist for elderly diabetes. Assess for level of functional dependency, that is the frailty, and there is a frailty score. There is a chart which shows at what level of frailty the patient has. Individualize the glycemic targets based on the above A1C, but if otherwise healthy, use the same target as the younger people. Avoid hypoglycemia and cognitive impairment. Select the anti-hyperglycemic therapy carefully. Caution with sulfonylureas or thiazolidinediones. because sulfonylureas are more prone to lead to hypoglycemia, and with thiazolidinediones, there may be water retention. The patient may go into congestive heart failure, and if there is associated any coronary artery disease or coronary heart disease, then also they may be detrimental. DPP-4 inhibitors should be used over sulfonylureas because they are supposed to be very safe drugs. Basal analogs instead of NPS or human 30/70 insulin, when we have to use the insulin, and give regular diet, give regular diets instead of diabetic diets or nutritional formula in nursing homes. And we all know that frailty is a widely used term associated with aging that gives rise to increased vulnerability. And these are the guidelines where we look for the A1C, we look for the blood pressure, and we look for the LDL cholesterol also. And the three American Diabetic Association, this Diabetes Canada, and the International Diabetes Federation, they have given various levels of HbA1c, various levels of blood pressure and of LDL. But if you look over this table, more or less, they are practically the same. Now, we see that adherence to the medication that improves the glycemic control, which we have seen here, the number of injections missed per week, and increase in HbA1c. If 2.1 meal-related injections are missed in a week, the increase in HbA1c is by 0.3 to 0.4%. If 2.1 long-acting insulin is missed, it is again 0.2 to 0.3%. 39% of all injections are if missed, and the HbA1c increased by 1.8%. So it is an inverse correlation between adherence to medication and the HbA1c values. Now coming to the insulin, because when we talk of insulin, if the patient requires insulin, the basal insulin analog, also known as the background insulin or the long-acting insulin, is to keep blood glucose level at consistent levels during periods of fasting, such as in between meals and while you are asleep. And when we talk of this, the insulin glargine, very commonly available, GL100, and the insulin detimers, they were developed to overcome some limitation of the early basal insulin, such as NPH, with less variable absorption and longer duration of action. Then came the longer acting basal insulins, and these are the insulin glargine, which has 300 units in 1 ml, and insulin degludec. They have since been developed with less variability and more prolonged duration of action, which we can see here. And when the deliver 3, this has shown that similar glycemic control with less hypoglycemia after switching to GLA 300 versus other basal insulins in real life elderly. Important thing is that hypoglycemia should not take place, and especially during night time. When hypoglycemia goes unrecognized, it will be detrimental. Patient may go into coma, there may be permanent brain damage, and even if we correct the hypoglycemia after some time, and when the brain injury has already taken place, there is no point. So in selecting the insulin, be careful that select those molecules which has less hypoglycemia, and especially the nighttime hypoglycemia. GLA 300 versus IDEC 100 in adults more than 70 years of age. The BRIGHT elderly study has seen that greater HbA1c reduction was observed with GLA 300 versus IDEC 100 in these ages. Hypoglycemia risk was similar with both insulin in these older populations. And another important point is that whichever insulin we choose, we have to look for the cost of therapy also. So in routine clinical practice, it has been seen that initiation of GLA 300 is safe and effective in elderly in routine clinical practice, but it is costlier than the standard glargine 100 insulin. Overall incidence of hypoglycemia event was low at month 6 and at 12 months. The advantages of basal analogs: it is simple and convenient to initiate, easy and safe to titrate, smooth maintenance period following active titration phase, effective in real practice, less glycemic variability and more time in range, less hypoglycemia and less weight gain. And on the other side, if you see ease of training, to train our patient how to take the injection, requirement of less monitoring, flexibility of using once a day, improved quality of life and patient satisfaction, ease of remote management, improved adherence, and lesser exposure. So to increase the adherence, we have to see that the medicine, the injection, this should be patient friendly. The training should be easy. There should be less monitoring, and very important is there should not be any hypoglycemia. So to summarize, the non-adherence causes and solutions, the basal way, multiple or complex regimes, fear of weight gain, hypoglycemia, poor or infrequent communication with SCP, cost and perceived lack of efficacy. We can see that the simple treatment regimes are available, better choice of insulin, improved communication, good value, and fast acting medications. So we can see that, but three things I have told you in deciding the dose. And when we talk of the adherence, then look for the cost, look for the efficacy of the drug, and look for the treatment regime, ease of administration. This everything we have to take into considerations, and with a good communication with the patient. If an elderly patient, if we can talk for 5 minutes, we can explain the patient, then I think it becomes much easy to increase the adherence. Thank you very much. Thank you for the patient here.
Thank you so much, sir, for that usual masterly lecture and many accolades. I think you have pointed out a few points very well. First of all, diabetes is not glycemic control. It's multiple illnesses put together, and therefore the pill burden is a lot, and that may hinder adherence. That is one. Second, we should not be, as my examiner, Dr. Amni, used to say, don't be a Bond 007. Don't keep 7% in all. Consider the patient, his frailty, his age, his comorbidities. And of course, avoid hypoglycemia, because that will really put the patient back. And I think generation 2 basal insulins have gone a long way. And of course, at the end of it, I think cost is a major factor which needs to be considered. Thank you so much for that brilliant talk, sir. And the house is now open for any questions.
Thank you, Dr. Dheeraj. Thank you.
Sir, myself, Dr. Jayant Sharma from Calcutta.
Hi, Dr. Jayant. How are you? Welcome.
Sir, good evening. Excellent lecture. And I'm very delighted to see all my seniors and my veterans in front of me, in front all of my OP Sharma sir and all the sirs are over there. Sir, one small question to you in your lecture, that can capital CAN, you have been mentioned in one of your slide and these things, that is cardiologic autonomic neuropathy. Can you highlight a little bit more on this point?
Thank you, Dr. Jayan. Cardiac autonomic neuropathy is one of the complications of diabetes, especially in long-standing diabetes. And we measure this by either by a machine or the simple tool. Even without a machine, you can look for, number one, change in the heart rate while the patient is supine, while the patient is standing, and with deep inspiration. Finer details you can have with a machine. And another important which we can do in our day-to-day clinical practice is take the blood pressure of the patient in supine, sitting, and standing. And if the fall in blood pressure is more than 20 millimeters of mercury systolic, that goes in favor of a postural hypotension. So with the cardiac autonomic neuropathy machine cans, we can detect all these features with the respiration, with the changes, variations in the heart rate, and variation in the blood pressure, even with the hand grip exercise also. So these are the various features which we look into this.
I think it's a very important question that has been raised by Jayan Sharma, especially in geriatric practice. Because of the age, there is an autonomic neuropathy. Because of the diabetes, there is an autonomic neuropathy. And there are certain drugs that are used for hypertension, which blunt the hypoglycemic awareness. So as a matter of fact, all the three combined have a great role to play. Thank you so much, Dr. J.K. Sharma, for accommodating us by sparing time from your Nagpur conference where you were extremely busy. Thank you very much.
Thank you, sir. Thank you very much for giving me this opportunity. Thank you, sir.
Thank you, Dr. O.P. Sharma, sir, Dr. Shankar, sir, and Dr. Das for involving me. Thank you so much.
Thank you for masterly chairing the session. Thank you.
Thank you, sir. Sir, I had just one comment what about that cardiac autonomic neuropathy. And I want to ask Sharma sir also, Dr. J.K. Sharma sir, regarding that, because we also in our hospital, government hospital, that is School of Tropical Medicine, we while running our clinical pharmacology OPD, we are also doing this cardiac autonomic neuropathy testing in our diabetic patients, specifically while modulating therapy. Specifically, I am giving few examples because lots of our patients who are coming with the symptoms of gastroparesis, and in our city, there is no testing for gastroparesis, that technetium dye-mediated thing and gastric emptying study. So we generally focus on that parasympathetic activity, specifically the Valsalva ratio and that inspiratory-expiratory ratio, and assume that if there is some parasympathetic abnormality present by this simple test of inspiratory-expiratory ratio or Valsalva ratio is changing, so we assuming that as there is parasympathetic defect and the symptoms is positive, so we assume this particular patient has gastroparesis. And according to that, we plan or change the therapeutics, just like the insulin timing. We are generally giving that regular insulin or NPG insulin. So what we prescribe 30 minutes before meal, in presence of this type of thing, we give just before meal or even after meal, assuming this particular patient has gastroparesis, and we get some good results also in that. So I need your expert opinion on this and whether we are doing right or anything need to be modified. Please give your valuable feedback, sir.
You are very correct, but I would like Dr. Dheeraj to comment on this.
Well, it's actually opening a newer vistas and very enlightening. We all know that the parasympathetic tract is the first to go in autonomic. That is one. The second is that, in my opinion, the patients do come with bloating and decreased appetite. That is the most common. But yes, since you have mentioned it, I think it's worth pondering upon. And thanks for opening a newer vistas for all of us.
Thank you, Dr. Dheeraj. There is a question, if our chairperson allow me, role of SGLT2 inhibitors in elderly, and another is nocturnal hypoglycemia in elderly. Nocturnal hypoglycemia, I already told you about that we have to keep in mind. And of course, we have to treat the patient accordingly so that the person does not go into nocturnal hypoglycemia and other complications. Regarding the role of SGLT2 inhibitors, the SGLT2 inhibitors can be used up to the age of 75 years, but again, we have to see for if the patient has any other comorbidity, if the patient is already on diuretics, if there is fluid retention, if there is evidence of postural hypotension, then we have to see. And especially in these summer months, when the patient is not able to take proper fluids, there may be fluid depletion, again leading to hypotension and all the complications. So this is a double-edged sword. They are very good, but they should be used very cautiously. The patient selection is very important, and treatment of any diabetic patient should be tailor-made. Thank you.
Yeah. I think let's thank the chairpersons and the great speaker. Thank you so much.
Thank you, sir.
We can go for the next session, please.
Thank you, sir. So we are now moving to our next session, that is on technology support in improving adherence in elderly patients. And to chair this session, may I invite respected Dr. Jayanto Sharma, who is senior consultant physician and a reputed geriatrician in Kolkata. He is now attached with Apollo Glingels Hospital, Kolkata. And with him, may I invite Madam Professor Mongola Broker, who is Professor of Medicine and eminent geriatrician from Aurangabad. I request our chairperson to introduce.
I'm a professor of geriatrics at Government
Okay.
Medical College, Aurangabad. Thank you.
Okay.
I used to be a professor of medicine 5 years ago.
Welcome you, madam. Welcome you, madam.
Thank you.
So over to chairperson, sirs and madams. Over to you.
Myself, Dr. Sharma from Calcutta, and along with me, Madam is there, Madam Professor Mangal. So the topic is very interesting, which has been suggested as well as kept in this scientific seminar today. The technology support in improving adherence in elderly patients. So the technology is gradually day by day becoming more common friendly for not only the patients, for all our daily activities also. And on this topic today, as we are all the doctors are over here and we are talking all the things about the clinicals, our scientific, that is sessions, as well as we are having a lot of maneuvers and drugs and these things. These are the two persons who are with us today. They are not the medicos, but they are the ITs or techos, you can say. So one is Mr. Rohan Tripathi. He himself is an engineer by profession, and he is one of the director of the Inovocare E-Academy, who is doing this whole program now today in this session. And along with this, Mr. Baljit Singh is there. He is also a techo, and he is from IT professional basically. Along with us among all the doctors and these things, we are really very happy to introduce both the IT professionals in our this symposium. So I'm requesting Madam to just start the session and to ask them to carry out the whole session regarding this technology support in improving adherence in our elderly patients.
Thank you very much, sir. And good evening to the elite speakers. We've had a wonderful session so far, and to the elite audience also. And as you mentioned, the technology is, it's a wonderful thing and useful not only for diagnosis, therapeutics, for helping, assisting the elderly for their activities of daily living, as well as instrumental activities of daily living. Then also for communication, entertainment, knowledge, finances, as safety. So many uses are there, and I would just like to add a very small experience in half a minute. That is, as you mentioned, I was a professor of medicine 5 years ago, and at that time I was the nodal officer of the ART center, and we had to keep reminding the people, the HIV positive persons. So on the previous day, my staff used to phone with on the landline. They used to phone all these individuals and remind them that they have to come for their medications next day. So that was a very simple exercise in adherence that I have a personal experience of, that worked well. And I'm sure that our elite speakers will definitely add a lot to our knowledge. Thank you very much. We welcome our speakers of today, as you mentioned, the techos, for carrying on this session.
Thank you so much, ma'am. Thank you so much, sir, for the introduction. It's really impossible for us technical people, unless we have proper help, support, and handholding from the doctors, like extremely caring doctors like you, to make something that at the end of the day can help people improve their lives. So without further ado, I would love to begin my session, because our time is limited. And I just want to say before I begin that it brings me a lot of happiness to mention that just previously we heard that there was a talk about the cardiac autonomic neuropathy. So we from Inovocare are also working on developing a system, a low-cost portable system of cardiac autonomic neuropathy. We are currently in the prototype testing, beta testing phase, initial testing phase, and we are carrying out the first testing round of 15 patients. So without further ado, I would like to share my screen and begin in just a moment. I hope my screen is visible to everyone.
Yeah.
Okay. Thank you.
Rohit, it is visible. Yeah.
Yes, yes.
Okay. Thank you. So I will begin with a few lines from the great ancient text, which basically deals with adherence. This part that reminds us to reminds the doctors to keep a watch on the patients. This is this is a bit direct. These lines are a bit direct and a bit strong, but let's ignore the language and take the message and move forward. That adherence is of essence, and this any film buff in the audience like me would recognize this still. It's from the 2019 starrer Martin Scorsese movie, The Irishman. The reason I use this picture is not only because I am a film buff, but due to the fact that this kind of a scene, that an elderly person struggling with his medicine, is not really a very uncommon picture. This is something that we often come across, and this is something that we want to change. Now, as it was mentioned quite a few times in this evening, that with age, comorbidity and polypharmacy increases. And not only that, I would like to mention that something that I think probably all of us have already witnessed, if not realized, that increasingly we are having, like we are always proud of the new India, the digital India, we are also having the new elderly and the digital elderly. We are having a new section of the elderly geriatric population that is more used to technology than was ever before. This is some data that is it's from a study that was from the US back in 2009. However, in the last decade, the digital change that we have come across that makes it much more relevant to us than what it would have been back 10 years ago. So as you can see from this data, it's evident that a lot of the elderly, they actually want help for regular medication reminding, and they want some professional support for it. My point being, with the increase of the general standard of life in every sphere, why have the same system for medicinal adherence as we had 10, 20, 30, 50 years ago? Why not increase technology, bring on technology into it? Now, since the outcome of outbreak of COVID, we have seen our elderly, even if only for having a face-to-face talk with their sons or daughters or grandsons or granddaughters, they have learned how to use WhatsApp. They have learned how to use Zoom, and they have come online. And maybe they have come online for their work, but they have adapted to it. And you would see slowly the technologies and the apps and the UIs are being developed in such a manner that they are being more and more geriatric friendly. So all this makes it essential to focus on the technology adoptions, the involvements that can improve the adherence in elderly care. Now, another thing, since such stalwarts have already talked a lot about adherence this evening, it would be sheer audacity on my part to talk more about adherence itself. So I have completely kept my brief presentation directly focused on the technology aspects. To begin with, let us see a case of augmented reality being used for medicinal adherence. This was from a study. This was a proof of concept testing back in Sweden, done in Sweden. You can see the traditional tick and cross being used to rely data over which medicine to take and which to not. However, through the smart glasses that you can see the person in the picture wearing. However, since due to the price factor of such a technology at this point, even at this point, which I'm sure will go down with time, this still today remains only a rare experiment, and though it's coming up very fast, still in the implementation point of view, this is very rare. Another thing that is coming up is gamification that is being used in adherence. A lot of medication apps are using gamification so as to give increased the kind of some cookie points, or making the adherence journey like a game, so that the elderly or the any person using them has a more added incentive to have their medicines on time. So we have a lot of apps that are coming on. You can open your Play Store or your Android, your iStore or Play Store, and there are 1,001 apps that you can download for your medicinal adherence. But can anyone say for medicinal adherence till today, which is the app that is being most used, which is the most used app? I can bet it's there in each and every one of your phones. And it's very similar to what ma'am just said. Anyone? In the chat box, anyone? Okay, it's WhatsApp. So back in Brazil, there was a randomized clinical trial of 403 patients, of whom there was an intervention group of 203 people, and there was a control group of 200 people. What they did was that for 4 months, they continuously supplied messages, instructions, pictures, videos to the group of 203 people, and the rest 200 people, they carried on medication in the normal course. And in 4 months, it was evident that there was around 15% increase in the adherence consumption. So this, though not being an absolute value, this was a clear indication how WhatsApp could be used. And I was very happy to hear ma'am say that they used to, earlier times they used to use just a phone. And it's amazing how much just a phone call helps. And WhatsApp can, because the visual medium is being added to the only audio medium, it can help even more in the adherence. So we had always had the old school, age-old things like the organizers, the medication administration units, where you can just plan your medication, but they lack any real method of adherence or medicinal compliance, so as to say. And this is the age-old plastic pill box that you can see. They sometimes even come with your alarms, but they actually lack a system of how would you understand if a person actually had their medicine or not. A proper system of what we can call as medicinal vigilance, like whether because as doctors you would often hear patients say that the medicines that you are giving are not working, only to learn that the adherence was the point of issue. So how to ensure that from devices like this? It's really very difficult. But these are at the end of the day, affordable, low-end devices. On the other hand, there are very high-end devices where the technology is state of art. They use AI and machine learning to give a great user experience and user interface. However, the price point and the infrastructure requirement is such that a majority of the Indian masses, makes very difficult to access this for the majority of the Indian masses. So, in order to bridge this gap, for the bring in the adherence provided by the high-end devices, coupled with the ease of access of the low-end devices, we from Inovocare Healthsoft Solutions have developed a device called MedpeR. It's basically a simple unit with that has your pill reminder, refill reminder, mesh dosage record, consumption record. There's an app that has a Bluetooth access. It's a completely portable unit. There's an older version, the newer version with the expandable range is coming up. We have the remote consumption tracking, as with your caregiver can sit anywhere in the world and track your medicine consumption. It can work completely offline, and it also has a Bluetooth, and it has also Wi-Fi mode, and it's a very flexible system. So what we want, and it's completely affordable and it's aimed at the Indian masses. So what we want to do is this kind of a device that can be combined while we all know about the National Digital Health Mission by the Government of India. This kind of a device combined with such a program that ensures single digital digital health data storage. This can do a lot for the entire medicinal adherence or medicinal vigilance journey. A doctor can have the entire patient's medicine consumption records upon his or her visit. All of you would understand how easy the process it goes, and it becomes very easy to understand that why the medicine did not work or what actually happened during the post-prescription journey. So we have come a long way with MedpeR. We have been showcased at various state and national events. And tonight, another feather is being added to our cap. So, and since we plan to enter the market this year, then we are having this 2021 from January, once every month, we are having a medicinal adherence awareness programs starting from January. This tonight is the 7th installment, which we are so grateful to organize in collaboration with the Geriatric Society of India that has been so kind to us to allow us to be a part of this event. So that is for which, the main aim of the journey is to make adherence accessible for all, adherence for all, and make the elderly truly independent. So that is the motion. So I would I would stop my screen sharing here. If there are some messages, if there are some questions, I would like to answer them going forward. And I would not stop you any further from hearing out, because there's Mr. Baljit Singh, a senior of mine, who is there with some really interesting things to show. So over to him and our respected chairpersons, if they have something to add. Thank you so much.
It was very interesting and informative. The only problem would be, how exactly do you install the app in a smartphone?
Ma'am, the main aim due to which we are making a device like this is, we found that traditional devices all require a smartphone to perform. So what we are aiming is, the device does not need a smartphone to perform. The caregiver with a smartphone can visit once a fortnight, and same caregiver can visit, say, for some 100 patients with a single smartphone. But at the end of the day, the end user, the elderly person, does not need neither Wi-Fi nor smartphone to operate the device.
I would suggest let there be second talk first, and then there could be question answers.
Thank you, sir.
Mind.
Thank you.
Sure. Thank you so much for the opportunity. First of all, I'm really honored to witness and listen to eminent speakers, dignitaries, doctors, and I really, feel very small in front of all of you. Very, very interesting talk. Though I'm not a medical doctor, though I wanted to be, but I've been listening very carefully to all the talks since last 3.5 hours. I would like to thank you, GSI leadership and patents, and also Dr. Tripathi for adjusting, my small 5 minutes a demo, I would say, rather than a talk, in the last minute. So I'm representing a company called Symbo.ai, which actually, very interesting aspect on how it helps adherence, because the device or the apps which you see in the market, they all need either the doctor or the patient, the entry to be done there, so that, the reminders can be done automatically. Now imagine an elderly person, let's say my parents, they have the app, okay, or the device, if the data can directly come from the doctor rather than they themselves entering or making any mistakes, would be wonderful. And that is where, you know, my talk is about this virtual doctor assistant, which is voice based, you know, to actually key in the EMR data into you know, your EMR prescription into the system automatically in a structured format, so that the system can directly start reminding your patients to come back for follow-up, to take medicines on time. Without wasting any time, I would like to directly jump onto the demo of the same, sir, with your permission.
Yeah.
Sure, thank you. So what you see on a screen is your, you know, login page. I've logged in as a doctor, general physician, and I have two patients, John M and Kyra, waiting to be seen. Let's say I'm going to see you know, John right now, and I see him, you know, seeing him for, let's say, giving him a treatment of dengue plan. Now, in order to, so on this screen, I'm not going to explain much. I'm just going to see that how within few seconds you can create your EMR record, okay, on this tool. Simbo pull dengue profile for adult. Temperature is 101. Simbo delete symptom number 3. Take Meftal tab SOS. Simbo sign off. Simbo confirm. I'm sorry I didn't let you see much action on the screen, but for that, but if you see what I did, I just talked. I said, hey, Simbo, bring my favorite dengue plan. It brought on the screen, and then I start making some changes, and I just said sign off, and it was done. I can take a printout of my prescription over here, on this. Sorry, I did not explain much. So I'm going to take you to another demo where I'm going to log in as an oncologist and show you lot more action on screen, but will not take more time of yours. Okay, so I'm logging out and logging in as an oncologist. One disclaimer here, sir. I'm not I'm presenting some clinical content which may be totally wrong as a prescription, live prescription. It is just a sample data to show you. Okay. Now, what I have logged in as an oncologist. I again have two patients waiting. Okay. Let me tell you what you see on the screen. Let's say I want to see Sneha. Now, right side is your prescription pad, sir, where Simbo will be writing on your behalf. You just talk. So I'll be talking, for example, as a doctor, and Simbo will be writing. So you can see on this screen the actions happening. Okay, left side is more on, like WhatsApp, what did you talk and what did Simbo understood. So without wasting any more time, I'm going to take like 1 minute or so to present, let's say, a sample onco prescription and going forward. Patient pulse rate is 76. Respiration rate is 16. Patient has skin thickening. She also has lump in the right breast. Go for mammogram and breast ultrasound. Also go for auxiliary nodal sampling. She is diagnosed with stage 1 breast cancer. Take tamoxifen 20 mg tablet once daily for 1 month after food. Also take anastrozole 1 mg tablet twice daily for 1 month. Go for CBC after 3 weeks. Come back and see me after 1 month. Simbo note a mass measuring 2 by 2 centimeter in the upper quadrant of right breast. Full stop. No pain and discharge. So let me quickly tell you what happened. I was just talking, it was identifying all complex clinical terms and, putting them into relevant section on your prescription pad, sirs and ma'am. For example, I said, come back and see me after 1 month. I was telling the patient, right? And Simbo was listening and say, okay, this is a follow-up advice by doctor. Today is 25th of July, 25th of August is the follow-up date. So it put it over here. Now, this is where it becomes important. This system, when integrated with system of Rohan or other apps, they can be auto reminders done automatically just after doctor saying this. There is no human intervention needed for calls or anything. Similarly, for example, I said, this anastrozole 1 mg tablet. Now, even though you see a line over here, but it is actually a structured data, medicine name, 30 days, twice daily, so that you can again start reminding this patient morning and evening for 30 days, for this particular tablet. So I think with this, I will just conclude this demo, but just to tell you how it helps in adherence, sir, for most of the tools, they actually need doctor to, type, use keyboard and mouse, so that we can remind, that data can be sent to the app and can remind elderly patients, or there are devices which can remind patients, but that does not happen, and hence the the dependencies on the elderly patient or their caregivers to enter that data, and it becomes a step which is reducing the adoption. So I think this is what I wanted to present. Hope this made sense to you all.
How would it remind the elders? If you have given the instructions, now how would the reminder come? Would it be a voice reminder, or it would be something like an alarm?
Yes, ma'am. So that can be, for example, let's say if we talk about Rohan's box, or we talk about an application or WhatsApp, it can be in any form, ma'am. The idea is that a computer is taking doctor's voice command. Doctor is validating that everything is fine. For example, I am validating that everything is fine, and when I say Simbo sign off, we integrate with Rohan's device so that it happens automatically. Now, or integrate with, let's say, there is another app which sends voice messages, another app which sends SMSs. So that can be anyone. It's just that this becomes a tool where you don't have to, ma'am, enter, but you just talk, and system will automatically remind. So it's not this system which will remind, but this will interface with systems which will remind.
Yeah, Baljit, what you have been told about the Simbo and these things, recently we have been experienced in our hospital, in Apollo Clinicals Hospital in Calcutta. So few, just like you, few IT professionals came to us, and they have been shown the demo to us. And I was sitting in front of the computer, that is a computer, and just like you, I was saying, well, I was typing one discharge certificate, but instead I was not writing anything, just I was having a command. So this patient is having a pain abdomen for last 7 days, and he was having a fever for 14 days. In the discharge certificate, what I am telling, it is automatically, it was writing or printing. But
right, sir.
As it was a very new thing for us, and these things, for initial 2-3 days, it takes some time for us to adjust on that. But after repeatedly and these things, my colleagues and juniors also telling, sir, it is a good one, and we can have these things in our hospital and these things. The hospital management is now seriously thinking on this way. So definitely this will be the near future. Hopefully we doesn't write down in the computer or laptop. We just having only voice command. So this is the tablet we have to take for the 3 days, 2 times a day or 3 days. So within next 6 months or 1 year, it will be really very popular in India, I think so. Because I have been really experienced what you have been shown in this platform today. This is a very recent one, just 1 week back, we have been experienced this one. So for that reason, definitely it will be a good one, Baljit. And what the Rohan is selling, and regarding that, so we need more, that is, you can say about the Rohan's one, more every month, or you can say again repeated reminder and these things. I have been not clear about the Rohan's concept and basics. So that is the thing. But as the Inovocare Academy and Rohan is trying to this, definitely it will be help us for the elderly patients and the medical personnel to have it more comfortable to our younger as well as the geriatric population to having the adherence as well as the adherence to the technology support regarding the medication as well as the treatment part. Thank you. Thank you, both of you.
Thank you, Dr. Jayant.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
So I'm just handing over to our organizer, and definitely our OP Sharma sir, our Kaushik Ranjan Das sir, so for this wonderful evening. So to the organizer, please, sir.
Lovely. It was a wonderful session. And the whole credit for this session goes to our President, Dr. Kaushik Ranjan Das. It was his initiative to have a dialogue with IHS people and introduce us to this new thing. Thank you so much. I would request Dr. Kaushik to kindly proceed with the vote of thanks.
Sir, vote of thanks will be given by Professor Shantanu Kumar Tripathi.
Okay.
Shantanu Kumar Tripathi, sir.
Yeah, sir, requesting Professor Shantanu Kumar Tripathi, sir, to give us vote of thanks, who is the mentor of Inovocare E-Academy. And he is now the research director of Institute of Liver and Hepatic Science in Kolkata, Sonarpur. And also he is the academic dean of Netaji Subhash Medical College, Patna. He is the principal investigator in the Covovax-Novavax vaccine trial, which is now ongoing in School of Tropical Medicine, a really promising vaccine candidate for COVID-19. So, sir, please bless us with your.
So thank you very much, Dr. Samazdar, and our very dear Dr. Kaushik Ranjan Das, Professor O.P. Sharma, and all other dignitaries. It was a great experience this evening. In fact, to have listened to so many great lectures, okay, and it was so needed for meaningful practice of geriatric medicine. Geriatrics as a discipline is coming of age. It was a long-awaited need, in fact, to be a discipline in its own right. And thanks to people like Professor O.P. Sharma and all other stalwarts that we are fortunate to listen to them today, that the discipline is now being recognized in the mainstream practice of medicine. And this is a section of the society which is otherwise, as a general rule, it is otherwise expanding thanks to advances in medicine as such, where our life expectancy is increasing. And we can no longer neglect the medical need of this section of the society, the geriatric age group. And it's great that we have been able to have spent this evening with so many stalwarts dealing with very important and significant areas in geriatric healthcare. And I have learned a lot. I'm basically a clinical pharmacologist, and we have been for the last few years, almost 7 years, we are actually trying to hold high the interest of the elderly people and their health interests in this part of the country. And we are fortunate that last few years we have come to contact with Dr. Kaushik Ranjan Das. With his encouragement and blessings, we have also been a part of this society. And so far as today's evening is concerned, I must thank the executive organization of the Geriatric Society of India, that they have agreed to have this program in collaboration with a young organization like Inovocare Healthsoft Solution, which runs also an Inovocare E-Academy, to have this joint event. And at any standard, everybody would agree it was an extremely successful venture. I was just wondering whether we can allow this great experience to leave it like that, or whether we have to continue the legacy. How best we can do that, maybe on a different occasion, we can discuss with Dr. Kaushik Ranjan Das, Professor O.P. Sharma, and all other stalwarts. that whether we can make best use of the very rich deliberations today and think of documenting them, okay, so that in future also, because most of the things that has been discussed are actually principles and also the hands-on experiences. So it is worthy to think of putting them together in the form of a document which can be referred to in near future by other practitioners of geriatrics too. I must profusely thank from the core of my heart to all the stalwarts of Geriatric Society of India and also all individual members of the society, those who spared their time with us listening to or attending this program, and even those who could not afford to attend today's program. All of them I must thank. I also take this opportunity to thank Inovocare, Healthsoft solution, to come up, join hands with GSI to have this program. I must thank all the learned speakers and the members of the faculty who spared their time and shared their rich experience with us in the different presentations, different lectures. And there were otherwise, after each session, there were also rich interactions, verbally, orally, and also in the chat box. Maybe some of the questions in the chat box, because of want of time, has not been discussed, but we'll try to also consider them and answer them by some mechanism. So with these few words, thanking the President, the Secretary, and all other office bearers of Geriatric Society of India, as well as the authority of the Inovocare Healthsoft solution, I take this privilege to end this Thanksgiving task of very pleasant task given to me. Thank you again. I hand over to Dr. Kaushik Ranjan Das.
Thank you, sir. Thank you very much. As a consequence of your talk, I want to draw kind attention of Officer sir. The Shantanu Tripathi sir has said to document the lectures, the documentation of today's lectures, sir. Your kind opinion, and I request you to wind up the session, sir. What to Officer sir?
Dr. Tripathi, we are grateful to you that you joined hands with our president and we had this wonderful session. Let me tell you, we are a sort of mixed class of people. There are seniors like Professor B.S. Shankar and Professor V.K. Arora to guide us, and there are people like Prabhadikari, always active, and there are young, dynamic, innovative people like Dr. J.K. Sharma, Sandeep Tamane, Anand Ambani,
yes,
etc., who keep on bringing newer and newer things. And we do have the tradition to have a seminar or a symposia or a lecture series and then bringing out the proceedings of that. And we do have a newsletter also, which is once in 4 months, but in that we bring out the proceedings. So certainly we'll do this thing and we'll join hands, and our young dynamic people, I would say them young because they are all between the age of 40 to 60, but they are young, whether it is J.K. Sharma, Sandeep Tamane, Anand Ambani or Kaushik, they are very, very dynamic and they always invite others. They believe in this thing that let's not have a watertight compartment. Let us share knowledge with others. Let us learn from each other's experience. We are a very open society and we'll certainly take care of this thing. I'm sure Dr. Kaushik is going to take the torch forward. He's going to be in touch with you. He's going to send the messages to all the speakers to get their lectures, and it will be done. And we look forward, and we'll be happy to invite you in our next annual conference as well, and to have a dedicated session for your
that would be great. Yes,
specialty.
That would be
good. Thank you so much. Thank you so much, friends.
Thank you. Before I close, just a second, that I just forgot. There are at least 2 persons who are not doctors in this whole gathering. Okay, we must thank them particularly. 2 engineers.
Yes, sir.
Mr. Baldeep
Yes, sir.
Singh and Mr.
Many,
Rohan.
many thanks to them.
Thank you very much.
Many, many thanks to them.
Look, Dr. Tripathi, I am only secretary. Secretary's job is sincerely yours. He is only to execute what the president asks him to do.
Right, sir. Right, sir.
Thanking is the job of president. Thank you. Pleasure.
Okay, sir. Thank you.
Thank you all, sir. Namaskar, sir.
Okay, JK. Okay,
Namaskar, sir. Namaskar, sir.
Okay.
Namaskar.
Dr. Mangla, Dr. Samrat, thank you.
Namaskar.